Okay, good evening, friends. How is everyone doing? I am Dr. Vivek Jain. We come to day one, part one, END of PSM Mission 3.0 early intern batch. How was the paper today? Those of you who have attempted, Dr. Shivang, Dr. Jasmine, Dr. Harsh, Dr. Ravi. How was the paper today? If you have attempted, how was it? Difficult? Okay, yes, actually, I have kept your NEET PG and INI-CET both in the mind together. Have you done the course earlier through main videos or mission videos? Have you done the course earlier through main videos or live mission videos? If not, then paper will be definitely appearing a bit difficult. If yes, paper should be appearing moderate to difficult. Moderate to difficult. Mission FMG, it will be slightly on a higher level because this is NEET PG and INI-CET, right? So don't worry. We'll go through all the topics one by one. This will give you an idea what type of topics, how the questions are asked in the paper, and we'll discuss in detail. Right, friends? So let us start. Let us look at today's paper. PSM END Part 1 Mission 3.0 Early Intern Batch. And I am Dr. Vivek Jain. Let's start with the first question. A researcher comparing two international indices HTI PQLI, which statements are true regarding these indices? Human Development Index, Physical Quality of Life Index. What are the three components of PQLI HDI? Let's go through it. See, my sessions are always interactive. Chat box will always be open. You can write in the chat box, right? Okay. So if you look at quality of life and human development index, they include two things common. Literacy rate is common to both, and life expectancy is common to both. What is difference is the life expectancy. One of them is at birth, one of them is at 1 year of age. So which of them is at birth, anyone? Which of them is at birth, PQLI or HDI? Which life expectancy we use at birth? Very right, Dr. Aditi is right. Life expectancy at birth. PQLI is life expectancy at 1 year. Difference lies in the second indicator. In PQLI, it is infant mortality rate. HDI, it is income. Now, confusion occurs in the paper as we have discussed in main videos and mission videos because they have multiple names. Like literacy rate is known as knowledge, also known as enrollment ratio, education index, and it is calculated by mean years of schooling. All of them are same. Similarly, income is per capita, or we can use for comparison US dollar, triple P, purchasing power parity. Life expectancy is also known as longevity. So this will become longevity at birth. Then as we discussed, these are also based on health, both of them, education and living standards. So this is another way of asking question. This is how PYQs help us. So education through literacy, health through IMR, health health is through life expectancy, and living standards. Earlier we used to measure through IMR, but nowadays we measure through income. So three components. And what is the range, friends? What is the range? Physical quality of life index lies between, HDI lies between. This is more commonly asked beyond the components. Very right. No, not 0 to 10. Yes, it is 0 to 100. Physical quality of life index lies from 0 to 100. And human development index is 0 to +1. Like if you look at India, it is around 65 quality of life. And human development index of India is currently 0.644. This is rank 134 in the world. So please remember, it is human development index which is more used now. Medium development. Most developed country in the world, rank 1.96, is Switzerland. So most developed country in the world is Switzerland. Now when we look at this and when you go through the choices which are given, you just have to read carefully. They are asking which statements are true. So when you look at statements, HDI includes income. PQLI does not. This is correct. PQLI considers gross national income as parameter. PQLI includes gross income. No, it includes infant mortality rate. Just now we have discussed. Instead of income, it is having physical quality of life index is having infant mortality rate. HDI uses geometric mean. PQLI uses simple averaging. This is correct. Both indices incorporate IMR directly. No. So correct answer is choice one, point number 1 and 3. That is choice number B. Can any one of you tell me? I'm asking a question which we studied in school. What is the difference between geometric mean and simple average? Simple average is arithmetic mean. What is arithmetic mean? Total sum divided by number of observations. Like in central tendency, we use mean median mode, right? So weight of all students in your class divided by number of students in your class. But what is geometric mean is you multiply all the values with each other and take the root value, which is the nth observation. Suppose your class has 3 students and their weight is 50 kilograms, 60 kilograms, 70 kilograms. So 50 into 60 into 70 and take its cube root. If there are 10 students, take 10th root of all the multiplication of the 10. No one will ask you, but this is just to tell you weighted geometric mean is taken in human development index, right? Okay. So question 1, choice B. So answer will be choice B. We move to question number 2, multi-dimensional poverty index. Multi-dimensional poverty index. Now, what is MDPI, friends? It is now the parameter which is complementary to development. As the development increase, poverty should reduce, right? So poverty earlier we measured through HPI, human poverty index. Nowadays we measure through multi-dimensional poverty index. Now let us look at MDPI is also based on 3 components: health, education, living standards, just like human development index. But human development index is achievement. MDPI is how much you have not achieved. That is deprivation is the word, or lack of these indicators. So let us look at in detail. We have discussed in main videos and mission videos also, but let's revise again.
Hello, sir.
MDPI, if you look,
Hello.
it actually comprises of 3 components.
Hello.
These are health, education, and living standards. When we look at health, health is measured by 2 parameters: nutrition, and what is the other one, friends? That is child mortality. When we look at education, it is years of schooling and school attendance. Years of schooling and school attendance. Living standards, this is based on total of 6 sub indicators. These are fuel, electricity in the house, assets, toilet. Toilet is the sanitation facility. Flooring of the house, that is the housing standards, whether it has been constructed properly or not, and the water supply. So if you look very carefully, friends, we have got in MDPI 3 indicators and a total of 10 sub indicators. Now, when we look at this MDPI based, it ranges between multi-dimensional poverty index ranges between, just like human development index, 0 to +1. Value of India, you are very right, doctor. Value of India, they will not ask, but you should know 0.069, roughly 16.5 4% of Indian population is below poverty line. Now, INI-CET always ask you question at a slightly higher level. So NEET PG will ask you Human Development Index or the Physical Quality of Life Index, but INI-CET will ask you Multi-Dimensional Poverty Index. So for INI-CET, you should also know, when we talk of Niti Aayog India, Niti Aayog is the new name of National Planning Commission. It has got 3 indicators, but 12 sub-indicators for poverty calculation in India. For poverty calculation in India. So in health, they include one additional adolescent health. And for living standards, they include one more. That is if the family or the person is having bank account. So what I will suggest, first you remember the 3 indicators, 10 sub-indicators of MDPI. This is according to global classification, all countries of the world. If you can remember that, then India has 2 additional sub-indicators. And based on that, they say India's population only 11.3% is poor. So by global guidelines, 16% is poor. Indian guidelines, 11% is poor. Now, friends, when we look at the choices which are given in MDPI, they have gone into slightly more detail. So when you look at question, you have to read carefully. They are saying which are incorrect. Look at statement 1. MDPI says 3 dimension and 10 indicators, which is right. You can call it 3 indicators and 10 sub indicators also. Then they say a household without access to drinking water within a 20-minute round trip. It is not 20, actually, it is a 30-minute round trip. When we assess the availability, then it is not 20, it is 30. So this statement is a false statement. MDPI considers a child not attending a school up to class 8th as educational deprivation. This is correct. It is taken as up till class 8th. Look at 4th. MDPI is heavily dependent on per capita income. Look carefully. Nowhere income is used in the calculation. So this is also a false statement. So they are asking which are incorrect. Statement number 2 and 4. Choice number B. See friends, when the questions come in the paper, they may not be so lengthy. Although now 40% questions usually come lengthy. But I wanted you to read each and every choice, realize, okay, paper is going to be very comprehensive. 2.5 lakh students will appear in NEET PG this year. So it's not going to be easy, right? Okay. So 2 and 4 is the answer. So we can mark answer choice number B. They're asking incorrect. Okay. This was an easy question. Can you mark what is the correct answer? A 35-year-old man dies due to preventable accident. Which is most appropriate to capture premature mortality loss? Actually, they have written everything in the question. Premature mortality loss. So, can you mark it in the question, friends? Yes, you are right. Answer is by PLL. Years of potential life lost. Let's look at them one by one. Can you tell me, older question, which is the best indicator of disease burden? Anyone, what is the best indicator of disease burden? Delhi, Dr. Prathi is right. So disability adjusted life year. What does it tell you? It tells you years lost due to disability or premature death. So if a person meets an accident, he is lying in the bed for 5 years. Delhi is 5 years. Someone dies 3 years before expected life expectancy. Delhi is 3 years. So how many years are lost due to LD and years of life lost due to premature death? So both of them in a single person, if you can add them also, then that will be disability adjusted life year. Sullivan index is exactly opposite. What is Sullivan index? DFLE. disability-free life expectancy. What is the meaning of that? Suppose a person has life expectancy of 65 years. He meets a road traffic accident. He is disabled on his bed for 3 years. Can you tell me what is the Delhi for this person? A person meets a truck accident, disabled for 3 years. Delhi for this person will be 3 years. So 3 years are lost due to disability. He was on his bed. What will be Sullivan index for this person? Sullivan index will be, see, disability free life expectancy without disability. So Dr. Harsh is right, 65 minus 3, that will be 62 years. No one will ask you calculation, Dr. Ravi, Dr. Harsh, Dr. Aniket. This is just to tell you that this is, yes, one is only looking at disability or premature death, other is looking without that, how many healthy years a person can live. YPLL is years lost due to premature death. So we call it as years of potential life lost. If he didn't die prematurely, how many more years potentially he can live? Hale, health adjusted life expectancy. This is actually the number of years expected to live in full health. This is for a newborn. So when a child is born, based on the current situation in the country, how many years of healthy life is expected to live, that is known as health expect health adjusted life expectancy. Now please remember, out of all of them, Delhi still continued to be the best indicator of disease burden. Right? So let's make it very simple. Delhi is disability or death. How many years are lost due to that? Sullivan index is opposite of that. Total disability free life expectancy, total life expectancy minus disabled, healthy life. Hale is how many years a newborn child is expected to live in full health. And YPLL is a component of Delhi. YPLL, you can say, is a component of Delhi. Years lost due to premature death. That YLL is also YPLL, you can say. This one. Kelly Muhammad Aris is quality adjusted life year. It is actually a combination of both. Here, if you look at these four, whatever is written on your screen, we are only looking at quantity of life. How many years a person lived in disability? How many years earlier he died? How many years are without disability? This is only quantity. But in Kelly, we also look at quality of life. So it's not just quantity, quantity plus quality. Can anyone tell me where do we use Kelly in management? Another question of your exam. Where do we use Kelly in management? Older question, friends. Anyone can remember? Kelly is used as a measurement of Doc Rocks. Slightly you are wrong, not cost benefit. It is used for cost effectiveness analysis. Kelly is used in cost effectiveness. Dr. Aditi is right. Cost effectiveness analysis. Let's move further. This was an easy question, provided you read carefully. I have all these questions I have made myself so that you can read them carefully. Just read them carefully. See, all of us know what is surveillance. Anyone remembers the definition of surveillance which is asked in our exam? Scrutiny of all factors of a disease with three parameters. What are these three parameters? Attention, authority, suspicion. Surveillance is of three types: active, passive, sentinel, which is giving you the biggest component of caseload. Active, passive, sentinel, which gives you the biggest component of caseload, friends. Yes, passive surveillance. Patient comes on his own. 90% of cases come on our own to our clinic in OPD. 8 to 10% we go to community to find. This is active surveillance. And whatever is remaining, maybe 1%, 2%, that is through Sentinel. So can you tell me, Sentinel, when we say remaining cases, what are these remaining cases? These are missing or hidden cases. So this is a correct statement. Look at statement number C. It supplements notified cases. Yes. Majority come through passive, some come through active. Remaining are supplemented by sentinel surveillance. And which disease? Sentinel surveillance is the major surveillance we discussed in the mission videos and live videos also, friends. Which disease? Sentinel surveillance is the major surveillance. Yes, Dr. Patel is right, HIV. So where do we do HIV surveillance? How do we do HIV surveillance? Which sites are used? INI-CET question. Which sites are used in National AIDS Control Program as sentinel sites for HIV? Suppose it comes as a multiple response question in INI-CET this year. How do you monitor HIV surveillance or HIV prevalence? What are the sentinel sites used? Where people give blood for some other purpose. At the same time, we test them for HIV. So this includes antenatal clinics. A female is giving blood for hemoglobin estimation. We estimate torch infections, HIV. We also use STD clinics. A person has come for diagnosis of syphilis, gonorrhea. We simultaneously test for HIV. And we use high risk groups now. Now, blood banks are not used currently. If you read 5-year older answer, blood banks were also there. In high risk groups, commercial sex workers we are using currently, injecting drug users, and men having sex with men. So we keep on monitoring prevalence of HIV in them. Whatever we find, we extrapolate on population, right? So specific clinical subpopulation is used. Answer to this question is choice number B. Routinely, in general population, we use passive surveillance and active. Why to waste sentinel surveillance on that? Sentinel surveillance is only for hidden cases. Can anyone tell me what is the current prevalence of HIV in the country roughly? They will may not ask you, but this is just to tell you. This is how we have arrived at this number. Is around HIV prevalence in the countries? No, 15 will be very high, Dr. Aniket. 15 means 1 out of every 7 or 8 persons is having HIV, which is not possible. HIV prevalence in countries now less than 0.22%. So 0.2% we can remember. 0.2%. Dr. Harsh is right. Question number 4. Read carefully. Again, this is an easy question. Anyone can tell me what is the sequence of components in spectrum of disease? Which occurs first? Which occurs last? Do we have disability first or impairment first? Do we have handicap first or disease first? Dr. Shivam has written correctly. It is disease. Everyone knows when a person is afflicted by an organism or in non-communicable disease. Impairment. Loss of any physiological, anatomical, psychological function or part of the body like amputation of a finger, amputation of a limb. Disability. After impairment, disability comes, person is not able to perform routine activity. What is routine activity according to WHO? Which other people of similar age or sex can perform. 27-year-old male unable to perform sexual activity considered normal for his age is a type of disability. And finally, handicap. Person is not able to fulfill his role in society. He is not able to earn for himself, family also. Right? This is the sequence of spectrum of disease components. Now read the question. Question assertion says disability can occur independently without impairment. It is not possible. Generally, it is not possible. First, impairment has to be there. Then only there will be inability to perform routine activity normal for age or sex. So this is not a correct statement. Look at reason. Disability is always secondary to impairment and restrict normal activities. This is correct. So answer is choice number D. See, whenever friends, assertion reason type of question comes, many times students are able to find assertion reason, which of them is true, which of them is false. But they sometimes get confused between A and B. Is R the correct explanation of A? So what is the simple thing? Here you write because. Suppose you find assertion is also right, reason is also right. Now read it like a single sentence. Assertion because reason is this. If it makes sense, that will become choice number A. If it is not making sense, answer will become choice number B. Right? So assertion reasoning questions first decide whether statements are true or false. Then if you want to see whether reason is the correct explanation of A, assertion, write because in between in your paper or mind, right? Okay. Let's move further. Question number 6. See, let us suppose you have not read about this. Friends, even then you can mark correct answer to this question. Even then you can mark correct answer to this question. They are asking which of them is not classified as a utilization rate. Facilities are there, but you are not able to utilize it. Right? So this is very right. Now let us try to understand by looking at the two types of healthcare indicators. First is healthcare delivery indicators. So this will include doctor population ratio. Can you tell me what is the population norm for doctor in our country? Doctor population norm we have discussed in our mission life classes, friends. What is that? Expected doctor population norm in the country is? Everyone has forgotten. You must have read somewhere. It is 1 is to 1000. 1 is to 1000. Doctor nurse ratio, anyone remembers? 3 nurses per doctor. 3 nurses per doctor is what is recommended. Then population bed ratio. How many beds are available for 1000 population? Population per health center. Anyone remembers? One primary health center is for how much population? Anyone remembers? One primary health center is for how much population in plains and hilly areas? Let us see how many remembers. Population per birth attendant. PHC is per 30,000 population in plains and per 20,000 population in hilly areas. Now, these are delivery indicators. Now, these are the norms population has to, uh, government has to create for the population. But at the same time, these are different from healthcare utilization indicators. How much of them are actually getting utilized by the population? So this will include percentage immunized infants, let us say. So suppose I tell you in India 76% infants are immunized for first year of vaccines. Then that is a type of utilization. 76% infants have taken that vaccine. Percentage received antenatal care. So out of all the pregnant females, 73% has received complete antenatal care. Percentage population using family planning contraceptive method. Contraceptive methods are available, but how many of them are getting utilized? Bed occupancy rate. India has 3 million beds for admission of patients. Out of them, how many are occupied right now? Is it 76%, 80%, 100%, or there is even shortage also? Then average length of stay in a hospital. On an average, every patient is staying 2.3 days in a hospital. Bed turnover ratio. Anyone can tell me what is bed turnover ratio? or interval? We have discussed in the classes. Anyone can tell me what is bed turnover ratio? Or when you come to live classes again, we will discuss there. Bed turnover is a patient leaves a bed, another patient is waiting to occupy the bed. Time gap between that is known as bed turnover ratio. Ideally, it should be older question of your paper. Ideally, it should be slightly positive, slightly negative, largely positive, largely negative. Bed turnover interval should be ideally anyone slightly positive, slightly positive. So friends, now you can see they are asking in the question which is not a utilization, that is choice number A. Population bed ratio is actually availability. How much beds are available? How much of those beds are occupied? That will be the utilization. I hope this concept is clear. Many such questions you can solve just by reading the choices also. Right, friends? Okay. Question 7. Okay, this is easy. Which of them would not be a primary prevention measure? All of us know levels of prevention are four: primordial, primary, secondary, and tertiary. If you go through main videos, if you go through live mission videos, we discuss this topic for around 45 minutes to 1 hour, right? So primordial is before risk factors, primary is after risk factor, secondary is early part of disease, tertiary is late part of disease. Primordial we achieve through health education, primary through health promotion, specific protection. Secondary level disease has started, early diagnosis, treatment. Tertiary disease is in progression. So disability limitation and rehabilitation. Now friends, when you look at these choices one by one, let's go through them. You will find breast self examination. This is one of the recommended screening tests in developing countries for younger females. Breast self examination can only detect, it cannot prevent breast cancer. So this is secondary level of prevention. Control of tobacco. Why will you tell the population control tobacco use? Because lung cancer is rising in the population. So risk is present. You are promoting health. So this is primary level of prevention. Radiation protection. Can anyone tell me what should be the thickness of lead apron? Anyone? Another PSM question. What it should be? Yes, 0.5 mm. So lead apron, we ask the attendant of the patient to wear. So this is risk is present. So primary level, specific protection. Cancer education. See, you will give cancer education to population because it is now rising tremendously in the population. Okay, these are the risk factors for this. These are the risk factors. So this is again risk factor is present. So they are asking which is not a primary is breast self examination. Now, if you use a code, friends, primordial 0, primary 1, secondary 1, tertiary 3. Let me see how many of you remember. How many of you remember? No, friends, health promotion, health education is same. Let's, Dr. Pathi, look at it like this. If I have to give health education to a group of smokers that stop smoking, this is primary level of prevention. Risk is present. But if I tell this to a 5-year-old child, do not start smoking in your life, same thing will become primordial. Same thing will become primordial, right? So this is primary level. Can you tell me if you are asked vaccines, which level of prevention is that? Any vaccine they ask you is primary. If they ask you BCG in bladder cancer, BCG in bladder cancer, that is secondary treatment. If they ask you contraceptives like condoms, level of prevention, condoms are primary. Risk is present, so they prevent pregnancy or HIV transmission, whatever it is used for. Can you tell me what is spectacles? A level of prevention. Primordial, primary, secondary, tertiary. Spectacles cannot treat refractive error. So it is tertiary. Disability limitation, rehabilitation, both or none. Spectacles are disability limitation, rehabilitation, both or none. Dr. Harsh is right, both. Disability limitation, it stabilizes your visual acuity. Rehabilitation, you take off spectacle, alphabets may not be clear, you put on spectacle, each and every alphabet is clear, you are visually rehabilitated. Both modes of intervention. If they ask you pap smear, which level of prevention should I mark in the answer? Yes, secondary. If they ask you biopsy, colposcopic punch biopsy for cervical cancer, secondary. So again, all screening, all diagnostic test is secondary. If they ask you dots, secondary. Can you tell me what is primordial level of prevention for malaria? Only one question was asked in opposite direction. Primordial level of prevention of malaria includes. Yes, you are right. Source reduction. Okay, good. So almost all answers I got correct in the chat box. That means everyone is very well versed with this topic. So levels of prevention will definitely come in your NEET PG. Please mark it correctly. Let's move further. Question 8. Question 8, friends. Can you mark this answer? This is actually based on one of your PYQs. Airborne isolation. Airborne isolation is done for measles. Let's try to see. See, when we look at transmission based precautions, these are known as transmission based precautions. They are broadly divided into three types. First is airborne precautions. Now, when we look at, friends, airborne precautions, this is where they are transmitted mostly by droplet routes or droplet nuclei less than 5 micron. This includes TB. You have to remember these examples. Measles. Most of the respiratory diseases, common ones like chicken pox. This is your first type. When you look at second type, that is separate from this, droplet precautions. Now, please be careful. We are not talking of droplet nuclei. Droplet nuclei is a smaller version of droplet. So droplets, when we look only, this includes droplets, you can say more than 5 micron. So diseases which spread mainly through them include mumps, rubella, diphtheria. These three you definitely have to remember. If you can remember, almost all pneumonias, streptococcal pharyngitis also between them. Yes, very right, Dr. Shivam. Distance between two person if less than 1 meter, not 1 feet, 1 meter, right? Then there is a chance of high transmission of respiratory diseases. Therefore, we ask the person to maintain 1 arm's length. Doctor-patient distance should be more than 1 meter. And third is the contact precautions. Contact precautions. This include diseases like Shigella, diseases like herpes, scabies. Scabies, what is the drug of choice, friends? I'll keep on asking you question. Scabies, what is the drug of choice? Wound infections. That is 5% permethrin, 5% permethrin. Now, these you have to remember. Can you tell me for COVID, which is applicable? For COVID, which of them is applicable? Can you tell me? Airborne droplet contact. Actually, for COVID, all three were applicable. It is not just through droplets, it is also through contact. So, droplet and contact were definitely there, right? So COVID all were applicable actually, right? Okay, so answer is measles. Let's move further. Question 9. I think this was a easy question. This you can mark correctly. What they're asking is continuous common source epidemic. I told you continuous is also known as repeated exposure, multiple exposure. Also, I told you common source is also known as point source. So, what is the answer? See, okay, let's see in detail. There are three types of epidemics. Look at the first one. This is single exposure point source. Like food poisoning, like Bhopal gas tragedy, what happens here? Sudden rise, sudden fall, and there is a clustering of cases in one incubation period. So this is characteristic. Yes, continuous means repeated or multiple exposure, Dr. Shivam. Absolutely. So this is single exposure point source. So it is characterized by clustering of cases in one incubation period. So you will find maximum cases occur in one incubation period. Second is multiple exposure point source. Multiple, also known as continuous or repeated exposure. Example could be like contaminated well in a village. Look carefully. Sudden rise, but fall is not sudden. There are multiple peaks because of multiple exposure. And there are, if you see carefully at the bottom, multiple times exposure, multiple incubation periods. So it's not a single incubation period. These multiple peaks are known as secondary waves. Very popular question. Secondary waves. HIV through a commercial sex worker is multiple exposure point source. Then look at the last graph. This is your sin, single exposure point source. But look at the second graph. That is your propagated epidemic. What is propagated epidemic? There is slow rise, slow fall. It is mostly seen in diseases which have person to person transmission, like tuberculosis, HIV, right? Okay. So you have seen all three types of epidemics. Now let's go to the question. Look at continuous common source repeated exposure. Repeated exposure will be like this. Sudden rise, but fall is not sudden. This one, second graph we discussed. So read the choices. It has high secondary attack rate. No. Most characteristic. Duration is always more than one incubation period. Duration is always more than one incubation period. If it is a high secondary attack rate, one case can give rise to multiple cases. More chances it will be single exposure point source. One person suddenly infects 30 more people, right? Okay. Rapid rise and fall is also seen in single exposure point source. Brief and simultaneous exposure, no. In multiple exposure point source, there is continuous exposure. It keeps on occurring again, 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 and again, right? So it is all a concept based question. I hope this question is clear that it was one of the easy questions of the paper today, right? Okay, let's move further. So answer to this question is choice number B. Question 9th, B. We look at question number 10. This is based on iceberg phenomena of disease. So which answer did you mark, friends? First we'll discuss the concept, then I'll come to the question. Okay, good. Everyone has marked correct answer. This is iceberg phenomena. It is having two parts, tip and the bigger hidden or submerged portion. Can you quickly tell me what does tip comprise of? What does hidden portion comprise of? Tip comprises of cases. People who are having signs and symptoms. Hidden portion comprises of carriers, subclinical, preclinical, latent, pre-symptomatic, asymptomatic. Very right. Tip is the responsibility of clinician. Hidden portion is the responsibility of, because they are also spreading disease, epidemiologist. How do you detect tip? How do you detect hidden portion? Can you tell me how do you detect tip? Because these are having the signs and symptoms. Directly use diagnostic test. Hidden portion is also having the disease, but signs symptoms is not there. So we go for screening test. Can you tell me which level of prevention is for tip? Which level of prevention is for hidden portion? Very right. Both are secondary. We just discussed 5 minutes ago. And what is this? Can you tell me? Level of demarcation lies between line of demarcation or level of demarcation lies between. What is the best answer? Very right, Dr. Shivam. Apparent and inapparent infections. These are all questions you get from iceberg phenomenon of disease. See, hidden portion is by carrier, preclinical, aclinical, asymptomatic, subclinical, latent, but mainly through carriers. So, 5 diseases who do not have carriers have no iceberg phenomena. No carrier means either they are totally absent or they are very few. Can you tell me which 5 diseases there are actually very few or zero carriers? No iceberg phenomena. Yes, measles, rubella, rabies, tetanus, pertussis. No carriers, no iceberg phenomena. Can you tell me which disease shows best iceberg phenomena in India? I have told all questions from this topic asked till today. Which disease shows best iceberg phenomena? Iceberg phenomena is shown by many diseases, but best is shown by, yes, you are right, malnutrition. Otherwise, Japanese encephalitis show. Otherwise, HIV also shows. Otherwise, influenza, Dr. Patel, you are right, also shows. Right? No, rubella is not controversial. Measles, rubella have very few carriers. Very few carriers means it will actually look like this. Still, it is no iceberg phenomena, right? So it's not controversial what happened in between. Measles and rubella, some carriers were found. So somebody declared on Facebook that iceberg phenomena is not seen now. Iceberg phenomena is seen because still majority is hidden portion in other diseases, but not in measles and rubella. We have to remember, right? So still everyone is visible above the water surface. Any sign symptom you find, you will be easily able to diagnose them. Easily able to diagnose them. Yes, all these lectures are always recorded and they stay in the app, right? So let's look at the question now, friends. We are looking at submerged portion. So we will go for community-wide screening programs. It is growing very large. Quickly apply screening program, find those carriers, start their treatment so that submerged portion can reduce and disease can be controlled in the population. Read the other choices. They don't make any sense. Exclusive treatment is for tip, whereas we are talking for submerged portion. Mass diagnosis is for tip. Restricting access. Why will we restrict access to healthcare? That makes no sense, right? Okay. So answer to this question number 10th is choice number C. Question 10th C. What is question number 11 say? Which of the following statement regarding evidence-based medicine pyramid is true? What is evidence-based pyramid, friends? All these studies are organized in the form of a pyramid. Can you tell me which study design is at top? In regular classes, mission classes, we discussed all study designs, formula calculation, but which study is at the top of pyramid? Very right, that is meta-analysis. Below meta-analysis, systematic review, RCT, cohort, case control, case report, case series. Then comes expert opinions. Can you tell me, friends, what comes below expert opinions? What comes at the bottom of the pyramid? Below expert opinions. Yes, animal research, and bottom of the pyramid is in vitro research. Can you tell me which of them is known as gold standard of evidence-based medicine pyramid? INI-CET question. Top is meta-analysis and gold standard is also meta-analysis. Best form of epidemiological study, most preferable studies, meta-analysis. Can you tell me, INI-CET question, who gave the concept of evidence-based medicine? Father of evidence-based medicine is? I'm looking at the chat box as you are typing. Yes, you are right. DL Sackett, David Lawrence Sackett. So you know about evidence-based medicine. Let's go to the question now. This is the question. They are asking which statements are true. Let's go statement by statement. When we look at statement number one, meta-analysis are considered higher in clinical relevance than individual RCT. Yes. Look here. Meta-analysis is here at the top, then review, then RCT. So no doubt at all this statement is correct. Look at statement 2. Cohort studies. Cohort studies rank higher than case control studies. Yes, because they are more accurate. Cause to effect they can prove very clearly through relative risk. Odds ratio are less accurate because they are associated with recall bias. Look at statement 3. Systematic reviews are considered unfiltered information. No, it also has filtered information. What is the difference between review and meta-analysis? Anyone? Slightly higher level question, but we have discussed in live classes and recorded videos. What is the difference between meta-analysis and review? Both are same except by meta-analysis is better. In meta-analysis, we also do quantitative synthesis of result. So systematic review, you study multiple studies together. Meta-analysis, you study multiple studies together and you try to calculate a single result also. Quantitative synthesis of a single result. You remember that forest plot. What is that single result known as, anyone? Let's make it a chocolate question. I'll give you a chocolate when we meet next. Dr. Shivam is right. Diamond measure in a forest plot is that synthesized measure. Very right. Look at statement 4. Ideas and editorial rank above case reports. No. Ideas, opinions, views, reviews, editorials don't carry any value. Case report, case series are always above that because there you are actually studying the case, right? So answer to this question is choice number A. Choice number A, right? Okay. Question 12. Okay, this is an interesting question. What I've tried to do is I have tried to combine four parameters into a single MCQ. I wanted you to read all the four. You should know for NEET PG how to calculate. So let us look at all the four. I will look at the correct answer later. But first you tell me, what is the crude death rate in this population? Can you calculate right by my side? What is crude death rate? Total deaths occurring in a country in a year upon mid-year population in 2000. So look at total population. It is how much? Mid-year 5 lakh. It is given in the question. Multiplier is 1000. And how many deaths occurred during the year is 3500. So this will come to how much? Crude death rate will come 7. Automatically it is per 1000 mid-year population. Right? Can you tell me what is the case fatality rate of this disease? Case fatality rate is fatality among cases. So deaths among cases. It is a proportion, so it is expressed in percentage. So it is written deaths are 700. You can see this one. This value is given. So deaths are 700. How many are total cases? You can see these are 4,000 into 1,000 into 100. Sorry. So can you tell me what will be case fatality rate in this population? This will come 17.5%. Very right. You are allowed to use mobile calculators because you will have on-screen calculators in the actual exam. So right now you can use your mobile calculators. Proportional mortality rate. Anyone knows what is proportional mortality rate? It is total deaths due to a disease divided by total deaths due to all diseases into 100. So you can see in this question, total deaths due to this virogen X is 700. Total deaths in the population 3,500 into 100. It is also not a rate, it is a proportion. So now we can see how much answer this will come. This will come 20%. Specific death rate. Chocolate question. Can anyone tell me how do we calculate specific death rate, as the word is telling you? Deaths due to a specific cause. So now this is a rate. This is not out of total death. This is per population. Very right. So this is total deaths due to virogen out of total population mid-year 5 lakh into 1,000. Many books mention it should be calculated 1 lakh. Many books mention it should be calculated per 1,000. That is fine with us. So if you calculate, it will come 1.4. Is it? So total deaths due to a particular disease, like in this example, Virogen X is 700 per 1 lakh population. Suppose you calculate it per 1 lakh population. You can calculate per 1 lakh also. Park says 1,000. Many of the literature mentions 1 lakh. So this will become now, yes, 140 per 1 lakh population. If you calculate it per 1,000, it will become 1.4 per 1,000. Right? So friends, this is how you calculate different. Now read the question. Question says, which actually you don't need to calculate. Question says, which is the best indicator of relative burden of virogen X deaths compared to all the deaths? So that is proportional mortality rate. Calculations I have done so that you know all the 4 indicators are important. See, I deliberately made this question slightly lengthier rather than asking you a question directly, because I want you to read everything in the paper, friends, right? Okay. Can you tell me, friends? I am asking question in opposite direction. Proportional mortality rate is also known as. Complete the answer. Let us see how many of us remember this old question. PYQ. NEET PG PYQ. Anyone? Yes, you are right. Excellent, doctor. This is simplest indicator of disease burden. Best indicator of disease burden is Delhi, but simplest indicator of disease burden is PMR. Very good. Let's move further. Question 13. Which of the following statement regarding standardization is true? See, a country's two countries' crude death rate, you cannot directly compare. Their age and sex structure is different. Their health facilities are different. So what we do is, what you have to know from this older concept is, standardization can be done in 2 ways: direct, indirect. Can you tell me when do we use direct? When do we use indirect? Direct standardization is used if age-specific death rates are available. Indirect are used if age-specific death rate is not available for that population. Then we use world population, some standard populations are there. Do reverse calculation, then apply on R. Next question, can you tell me how do we calculate indirectly standardized death rate? That is known as standardized mortality ratio. Observed deaths over expected deaths into 100. Can you tell me another older question? Which standardization method is better? Friends, direct is better or indirect is better? Which is better? I'm looking at the chat box. Can you tell me which is better? Yes, direct is better. Friends, can you tell me, for indirect standardization, we use standard populations in the world. Which are the two standard populations used if you want to use? One is SEGI population. One is standard European population. You have to remember these names. No one will ask you to do all the calculations in a MCQ, but we should know this concept. Now read the question number 13. Answer to this question is, they are asking which is true. Yes, indirect standardization is observed deaths upon expected deaths into 100. Look at the other choices. SMR is for indirect. Look at choice A. Direct can only be used when age-specific death rates are available. Right? Let's move further. Question number 14. This is again a tricky question for NEET PG, but very easy question. What is the answer you have marked? Friends, what is attack rate? Attack rate is incidence only, but expressed as percentage. So let us calculate. Attack rate will be, if you look at incidence, new cases upon total population at risk. Instead of 1000, we use 100 because attack rate is calculated in percentage. So now you can see new cases are 250 develop dengue during the monsoon. Total population 5000, all of them are risk. Dengue, we are not using any vaccine currently, into 100. Right? So it is 5%. At the same time, look at prevalence. Prevalence is total cases in the year, new plus old, upon total population into 100. So total cases are 400 simultaneously, new and old, divided by total population into 100. Right? So this is 8%. So it's again one of the easy questions of the paper. NEET PG gives you these questions which appear lengthy, but you know the formula concept, it is easy. So question number 14, correct answer is choice number A. This is clear, friends. Then we move forward to question number 15. Again, it is a concept-based question. Again, it should be, what should be, okay, sorry. In previous question, what are you saying? Where do you want to use 150? Where do you want to use 150? See, 250 developed during the monsoon. They are saying at the peak of epidemic, 400 were having new plus old. And read the question. They are saying what is the point prevalence? So they are asking at that point of peak of epidemic, 400 were the total cases having the disease. 400 were having total disease. Right? So 250 developed new fever during the monsoon. At the peak, total became up to 400. So incidence and prevalence separately given, right? Okay. Which statement is incorrect? It is all the concept. Now, relative risk. You revise with me. Relative risk formula and interpretation. Formula is incidence in exposed divided by incidence in non-exposed. More than one association is present equal to one, no association less than one. Inverse negative association, risk factor is protective. Now, relative risk is 2.5. What does it mean? It means disease is 2.5 times more common in exposed as compared to non-exposed. Attributable risk. Formula. Incidence in exposed minus non-exposed upon exposed into 100. Attributable risk. How much of the disease is attributable to risk factor? So 60% of this disease is due to that particular cause. You are absolutely right in the chat box. Then population attributable risk. Incidence in total minus incidence in non-exposed upon incidence in total into 100. If you modify or eliminate risk factor, how much reduction of disease annually will occur in the population for new cases? 15% new cases will reduce every year. Absolutely right. So now let us read the choices. They are asking, see, one thing is you have to read the question. They are asking which statement is incorrect. So let's go statement by statement. Obese woman is 2.5 times as compared to non-obese. So this is definitely a correct statement. 60% is attributable to obesity. AR is 60, that is correct. 15% new cases will reduce if obesity is eliminated. Population attributable risk. So answer is, incorrect statement is choice number B. Eliminating will not prevent 60%. It will prevent roughly 15%. Right? Question 16. Advantages unique to nested case control study. Now, before coming to this question again, friends, let us try to see what exactly is a nested case control study. See, we take a group of people who appear healthy, take their samples, take their history, forget now. Store them, refrigerate these samples. Now you keep on moving in forward direction. Whenever a new disease occurs, you come back and check the history or the blood samples. So a small case control study nested in a big cohort study. It is used for new rare diseases which have expensive diagnostic test. And which property of cohort study it is able to maintain? Temporality or forward direction. Keep that in mind. Now, when you look at question number 16, they say which of the following advantages are unique to nested case control. Let's go statement by statement. They have long internal validity. This is correct. This is a true statement. Why? Because due to minimal bias that we create in this study, everything is happening in front of your eyes. In front of your eyes. Plus, in case control study, you try to have a selection bias also like RCT. You try to select cases and controls according to your own choice. Here you are starting with a healthy population for many years. So that bias of selection is reduced. So it reduces selection bias. Then prospective exposure data is available. This is correct. Everything is happening in front of your eyes. Happening in front of your eyes. In case control, disease has already taken place, so risk factor history you ask. So very difficult to find it correctly many times. Lower cost than full cohort analysis. Yes, you cannot go back in time in an acid case control study and test all the 10,000 healthy people history and blood sample, but cases and controls you can study. Better external generalizability, no. Why it is not possible? Because actually this is limited, because it is depends on the cohort we have taken. $10,000 healthy people you take today to start nested case control study. So it will depend on those 10,000 people you have chosen today. So difficult to generalize it to any other population in any other country. And also the problem is it has a limited sample size when the final disease occurs. New rare disease, rare means it will be lesser number of new cases of that disease. So definitely it will be a limited sample size. So external generalizability means external validity. So internal validity is good, but external validity is very poor in a nested case control study. So advantages are choice A, 1, 2, and 3. 1, 2, and 3. New rare disease, which is likely to occur in the future. Right? Okay. Question 17. See, read the questions carefully. New vaccine, single elite hospital with young healthy volunteers. Same concept we were discussing here, internal validity, external validity. Which is correct? Will it have good internal validity, good external, or both? Yes, it will have high internal validity because you are doing a trial very correctly for a vaccine. In vaccines, we use healthy volunteers, right? So when you do it in a single hospital, everything is under your control. So internal validity results are very trustworthy. You are absolutely right, Dr. Shivam. But you are done it in a single hospital, that too with young healthy volunteers. So only that hospital cannot be extrapolated to other hospital, other cities, other countries of the world. So it will have very low external validity or generalizability. So answer is choice number A. So when you do study in a very small setting, results will be very good internally, but externally results will not be valid. Good. Question 18, we have just discussed, which is not a feature of nested case control study. This is the design of a nested case control study. Take population, go forward for many years. When disease develop, those are cases. From other people, select controls. Then come back in backward direction to compare their history and blood samples or any other thing. A small case control study nested in a big cohort study. Suppose you started with 10,000 healthy people today. After 20 years, 50 develop disease. So 99, 50 are healthy. Out of those, all 50 become cases. You can select 50 or ideally 200 controls. Then you go back in time and compare. This is a nested case control study. Now read the question. Which is not a feature, it is saying. Which of them is not a feature? Read the question carefully. It's very easy. We have discussed nested case control study right now twice, which is not a feature. See, it is in a forward direction. So it will reduce recall bias. Everything is happening in front of your eyes. Very good study design. So high internal validity, poor external validity. Controls are selected from the cohort only. You can see even controls are selected from that cohort of 10,000 people only. So answer is not a feature. Exposure data is not collected after the outcome develops. Exposure data is collected at the start, but when disease occur, then we come back and check that external data. So data is collected at the start. It is analyzed later when the new rare disease develops. Right? Dr. Isagi is right. Question. Okay, so again, this is B. Question number 19. First, you tell me this is which type of study design? Nested cohort won't be asked, Dr. Archita, that we can skip. Dr. Anchita, sorry, we can skip. Yes, this is a ecological study. Can you justify your answer? Very good answer. Why it is a ecological study, friends? Why it is not cross-sectional? Why it is ecological, Dr. Shivam, Dr. Shubham? Okay, population may be used in cross-sectional also, ecological also. No, I need the correct technical epidemiological answer. Ecological study because it is secondary data which is used. Data is not collected by the investigator himself. Read the question. He is looking at cities have higher rates of green space, lower rates of asthma admissions. So it's just taking data and giving a conclusion for the population. Now, population, you can give conclusion, but in ecological study, same conclusion is not applicable on individuals in that population. So when you try to say that every child living near park will have lower asthma risk, this is not possible. You cannot extrapolate results of the population on individual. This is known as ecological fallacy, one of the major disadvantages of ecological study. And can you tell me what is the other name of ecological study? Anyone? Yes, Dr. Anchita is right. Third party data, we can say. Ecological study is also known as anyone? No, prevalence study is cross sectional study. Dr. Anchita is right. Ecological study is correlational study. Very good. Can you tell me how ecological study is different from all other analytical studies? Can you tell me how ecological study is different from all other analytical studies? It is only difference in one point. That is unit of study. Unit of study in all analytical studies is individual, but in ecological studies, population. Therefore, you cannot apply results to every individual like every child living near the park. Good. Question 20. Now, this is a slightly higher level concept, but once it was asked in INI-CET, so we will go through it. What is confounding? Confounding is any factor associated both with exposure outcome. It will give wrong result. Like coffee consumption in pancreatic cancer. A study found people who consume more coffee are having more pancreatic cancer. But actually, coffee has nothing to do with pancreatic cancer. Later, it was realized coffee consumers also tend to be higher smokers, and smoking was leading to pancreatic cancer. So, smoking acted as a confounding factor in that study of coffee consumption leading to pancreatic cancer. Effect modification, slightly different concept. Effect modification is where third variable is there in this study and its magnitude determines outcome. Try to memorize the examples I am telling you because similar examples are likely to be asked. You're estimating smoking leading to lung cancer. By chance, smoker works in a asbestos factory. If he is exposed more to asbestos, more chances of lung cancer. Someone is going to asbestos factory only once a week. Someone is going 5 days a week. So 5 days a week, both may be similar type of smokers, but 5 days a week, effect will be modified more for development. Now, if you look at mediator, mediator is where a third factor in between. There is a third factor in between risk factor and disease, and it influences outcome. Like we must have studied in our gynae ops, multiple sex partners increases risk of cervical cancer. So it is not multiple sex partners directly increasing cervical cancer. In between, there is a mediator. And what is that mediator having multiple sex partners? Increased HPV exposure. That will become the mediator. And finally, fourth one is collinearity. Now, friends, when you look at collinearity, so we have confounding, effect modification, mediator, collinearity. Collinear means two things are related to each other. So what is collinearity, friends? Collinearity is two factors are so closely related not possible to distinguish individual effect. Suppose I say air pollution and urban area, they lead to more lung cancer. Both of them have contribution in lung cancer. But if I ask you to quantify air pollution and urbanization, it becomes very difficult to quantify air pollution is more responsible or urbanization is more responsible. This is collinearity, right? So these are four types of related concepts. NEET PG will only ask confounding. INI-CET will ask effect modification mediator collinearity only once. Read through the question. Now read the question. What does this question number 20 actually say? It says alcohol consumption and liver cirrhosis. So this is clear. Alcohol is the risk factor. Liver cirrhosis is the disease. Association is found to be much stronger among patients with hepatitis B. Association is found to be much higher in hepatitis B. All of you know hepatitis B also is related to liver cirrhosis. It's not related to alcohol directly. So it is not a confounder. This is an effect modifier. So how much hepatitis B infection quantum of viruses is there? That will lead to the outcome being wrongly measured. This is known as effect modification. So read these definitions 3-4 times, right? Okay. These four. Question number 21. Okay, friends, before coming to this question, can you tell me, can you tell me what are the different methods for removal of confounding? We have 6 methods. Matching, simplest, most commonly used. Randomization, one of the best methods. Restriction, stratification, where grouping is done, and statistical modeling, which is done by multivariate analysis. But overall, the best method is stratified randomization. If it is not in the choice, randomization is second best. We have discussed, right? Now we are having A&D, therefore we are going slightly faster. Otherwise, all these topics we have discussed in detail in recorded videos as well as live mission videos, all these topics. Now look at the question. They are saying stratification is attempted, but it failed. Why? Strata are too small. Key word in the question, which method is better for multiple confounders simultaneously? Answer lies in the word multivariate analysis. Multiple variables are analyzed together. So multivariate analysis through regression will be used in this particular study design. Multivariate analysis or multivariate regression analysis. See, what is the importance of using multivariate regression analysis actually? Here you can hold the other factors constant. So you can study one variable, one confounding factor, holding others constant. What does it mean? Suppose a study has three different confounding factors: age of the person, sex of the person, rural urban residence. I want to study the confounding effect of age. Then sex and rural urban I can keep constant and study the effect of age. Then I can separately study the effect of sex, keeping the other two constant. Then I can study separately the confounding effect of this rural urban, keeping the age and sex constant. This is multivariate regression analysis, higher level topic for INI-CET. Question 22. This was an easy question. We have studied meta-analysis have multiple disadvantages, although it is the best study design. What is GIGO principle? Garbage in, garbage out. If you put in poor studies in meta-analysis, poor result will come out. Publication bias, also known as file drawer effect, systematic heterogeneity. Always, Some studies are never published. They will never become a part of your meta-analysis. Maybe they were not accepted for publishing. Maybe they are still incomplete. Maybe they are still going on. This is found by which graph? Can you tell me, friends? INI-CET question again. Publication bias. Which graph is used? File drawer effect, systematic heterogeneity is assessed by anyone? Yes, funnel plot. Good. Asymmetric funnel plot means publication bias is present. Apples and oranges effect. Although we are combining multiple studies together, but to be frank, they may be done in different settings, different sample sizes, different type of environment, different type of other factors. So we are actually combining apples and oranges together, which is not a good thing. Recall bias is generally seen in case control studies where people are not able to remember their history. Now read the question. Question says substantial variation among included studies regarding aspirin dosages, patient ages, and outcome definitions. So what is happening is there is variation among the included studies. So this is, yes, apples and oranges effect. If they tell you same question like this, included studies were very poorly done. Final result is also very poor. That is known as GIGO. Garbage in, garbage out. So read the question carefully. This was a easy question. Question 23. Hill's criteria. Now, friends, Hill's criteria of causal association. What is the other name of this? Anyone can tell me? What are the other name of Hill's criteria? Suppose question comes by its other name. These are known as Surgeon General criteria. These are many of them. Temporality is most important. Temporality means forward direction, cause to effect. Specificity is most difficult to establish, so least important. That disease occurs only due to one cause. Strength of association, we know relative is odds ratio. Consistency, different settings, results are replicable. Biologically, they should be explainable or plausible. Coherence, one study result supports results of other studies. Dose increase, response increase. Number of cigarettes smoked per day, more chances of lung cancer. Cessation of exposure should reduce the disease. This is not applicable on pneumoconiosis. Now read the question. It says, which of the following statements are true? Which of the following statements are true? When we talk of specificity, they are asking, it implies a single cause leads to a single effect. This is correct statement. It is the strongest proof. No. Rather, this is the weakest link. Most difficult to establish. Therefore, we generally say, if you want, you can skip specificity. You can skip proving specificity. It is difficult to establish because diseases have multiple causes. Absolutely. Specificity is more critical for infectious disease. Yes. So answer is choice number B. Choice number B1, 3, and 4. Hill's criteria are analogous to which criteria in microbiology? Hill's criteria, question 22, answer was apples and oranges effect. Hill's criteria of PSM epidemiology is analogous to which criteria in microbiology? These are Koch postulates. Dr. Ravi is right. Koch postulates. Who gave Koch postulate? Robert Koch, right? Okay. Question 24. This was an easy question. Which statement is correct about serial interval? See, incubation period, entry of organism till first sign symptom. Serial interval, gap between primary and secondary case. Generation time, entry of organism till maximum infectivity. These definitions we know. Now you have to read about serial interval. Which statement is correct? Yes, Dr. Aditi is right. All these serial interval, generation time are indirect measure of incubation period. Serial interval is not longer. most of the times it is rather lesser than generation, because generation is till the infectivity of the person, which usually increases slowly after the signs and symptoms are set. Attack rate, no, it cannot tell you attack rate. It only tells you time gap between primary and secondary case. Serial intern applies only non-communicable, no. Primary and secondary, we are more talking about communicable disease. Latent period applies to non-communicable diseases. So correct statement is choice number B. Which contraindication to vaccination is true? Okay, let us go statement by statement. Typhoid vaccines are safe to administer in febrile illness, no. Which two vaccines are contraindicated in fever? Typhoid and what is the other answer? Which two vaccines are contraindicated in fever? Typhoid and which is the other vaccine? These are COVID vaccines. So typhoid and COVID vaccines are contraindicated in fever. Look at second statement. Yellow fever is contraindicated in infants less than 6 months only. No. When we look at vaccines which are contraindicated below 1 year, that include yellow fever, meningococcal meningitis, and pneumococcal. When we look at vaccines which are contraindicated in less than 2 years age, this includes meningococcal meningitis, pneumococcal, and typhoid vaccines. Nowadays we do give, but generally typhoid vaccines avoided below 2 years of age. So remember them as two different things. So yellow fever is not just contraindicated below 6 months. It is contraindicated actually below 1 year of age. Look at choice number C. Pneumococcal vaccine is contraindicated in a child below 1 year. This is correct. They are not using the word only. So this is the correct statement. They're asking correct statement. Choice number D. Pertussis vaccine is contraindicated in epilepsy controlled. No, it is uncontrolled epilepsy. Active seizures, it is contraindicated. So controlled epilepsy is non-progressive like cerebral palsy. In these conditions, pertussis is not contraindicated. Right? Okay. Now, many types of adjuvants are used in vaccination. Many types of adjuvants we use in vaccination. Can you tell me the adjuvant of DPT vaccine? Because till now in our exam, questions have only come from adjuvant of DPT vaccine. That is aluminum hydroxide. But nowadays, many vaccines have squalene based MF59 as the adjuvant. And this is the vaccine which leads to a severe local reaction inflammation at the site, and this leads to increased immune response. Why will this increased immune response occur? It is due to more robust T cell response. More robust T cell response. So this you have to remember. Question 27, which is correct? This was an easy question. Both statements are correct. Both are false. One is correct. Two is correct. What is the correct answer? Which is the choice you have marked? Dr. Aditi is right. Both statements are false. Vaccine associated is mostly associated with killed. No. This is the advantage of killed IPV. VAP and VDPV are only associated with OPV live Sabin vaccine. Cholera and yellow fever are the only vaccines which cannot be given together. There should be a gap of 3 weeks. Otherwise, they will interfere with each other's absorption and immunity formation. 28. Which vaccine is not allowed to be reused? Even if expiry date, cold chain, VVM, aseptic, these are maintained. Can you tell me which concept we are talking of? This is open vial policy. Open vial policy is valid up to how long? Can you complete the answer? Open vial policy is applicable up to 28 days. Can you tell me for which vaccines it is applicable? For which vaccines it is not applicable? It is applicable on T series of vaccines. So, hepatitis B, DPT, DT, TD, TT. It is applicable on pentavalent, which includes Haemophilus influenza B, OPV, IPV, both live and killed. It is also applicable on pneumococcal conjugate vaccine. It is not applicable on lyophilized vaccines, powder vaccines, BCG, yellow fever, measles, MR, MMR. Not applicable on Japanese encephalitis, not applicable on COVID vaccines. Now the only question remains rotaviral vaccine. Where should I put rotaviral vaccine? Applicable, not applicable. We discussed in all our sessions till now. If you have attended live mission classes or you have gone through rapid revision videos or the main videos, actually it falls in both. When we look at rotaviral vaccine, where VVM is on side of the vial, it is applicable. Whereas same rotaviral vaccine, if VVM is on cap, open vial policy is not applicable. This you have to remember. So let me highlight. So you can see if it is on the cap, open vial policy is not applicable. If VVM is on the side of the vial, it is applicable. So it is only applicable when VVM is on the side of the vial, right? Okay. So read this question. Now it becomes easy. Not applicable for measles vaccine. See, idea is not to discuss this question, but to tell you all related answers. See, why rotavirality is different is because we are replacing the older stock. And by chance in the program, both stocks are available, Dr. Abhinaya. So what is happening is both stocks are available. So we have clarified. So VVM on-site use, on cap, do not apply open vial policy, right? So when this stock is finished, then we will shift to a single policy. Okay, easy question. 10-week, which vaccine should not be given? What is the answer? Yes, good. JE Life. At 10th week, we give DPT2, OPV2, Hep B2, HIB2, rotaviral vaccine 2. Anything else which is given at 10th week? Do we give FIPV? Do we give pneumococcal conjugate vaccine? Answer is no. They are only given at 6 weeks and 14 weeks. 6 and 14 weeks. Be careful, Dr. Isagi. So, JE live vaccine, first dose is given at 9 months. Second dose is given at 16 to 24 months. Right? Okay. This is not just 23-24. Latest schedule also. Latest schedule also. Okay. Additional intervention for MIP vaccine. MIP vaccine means which disease are we talking of? It is first available leprosy vaccine developed in India. Here, name of the person who developed this vaccine is Pran, GP Talwar. In the name of the vaccine, if you look carefully, NII. This was developed at National Institute of Immunology, Delhi. Unique feature of this vaccine, it has to be given along with a single dose of rifampicin. It has to be given single dose of rifampicin. Can anyone tell me the reason? Chocolate question. Why it is given along with the single dose of rifampicin? By chance, someone came in contact with a case recently. So we are taking of that by giving a single dose only. Okay, friends, can anyone tell me what is the older name of this vaccine? We removed that name because it was creating confusion in the minds of doctors. That is Mycobacterium W vaccine. It's not the bigger W, it is the smaller W. Already there is a Mycobacterium capital W vaccine in the world. So we were using smaller W to avoid confusion. This name was deleted and it was changed to MIP, Mycobacterium indicus pranae vaccine. So please remember, it is not bigger W, it is the smaller W, right? Okay. Question 31, likelihood ratio. Now, only concept you have to tell me. See, when you use a screening test and suppose it comes positive, is it a guarantee person has the disease? No. Therefore, we confirm with diagnostic test. Suppose a screening test comes negative. Is it a guarantee person is absolutely healthy? No. Screening test may come wrongly negative also. Now, how do we interpret it in terms of likelihood ratio? Suppose likelihood ratio of a positive test comes 4 and likelihood ratio of the same negative test comes, let us say, 1 by 4 or 0.25. Now listen to the language I am telling you. What is the interpretation of likelihood ratio? Likelihood ratio of a positive test means if the screening test has come positive, how many chances of person actually having the disease has now increased? Let's look at it like this. Suppose a female came to you with for pap smear. You do pap smear. It comes positive. So when she came to you, you asked history, you observed signs and symptoms, you said you may be having cervical cancer. You did the pap smear, it comes positive. Now her actual chances of having cervical cancer has increased 4 times. So how many times chances of actually having the disease increase when the test come positive? Still, it is not 100% guarantee, so we go for diagnosis. Now suppose same pap smear comes negative. Now, what will we tell the female? When you came to me with history, signs, and symptoms, I thought you are having cervical cancer. Your pap smear has come negative. Now, your actual chances of having cervical cancer have reduced to 1/4 level. It's not a guarantee. You may be having, you may not be having, but at least the test has come negative. Actual chances of you having the disease have reduced to 1/4 only. This is the meaning of likelihood ratio. So, friends, you have to understand this concept. Answer is choice number C. It is helpful for confirming the disease. It is helpful for ruling out the disease also. But again, the final say will only be through the diagnostic test in question. Can any one of you tell me, friends, what is the diagnostic test of choice for cervical cancer in the National Cancer Control Program of India? Anyone? I'm looking at the chat box. Dr. Anchita, Dr. Accidental Dog, Dr. Aditi, Dr. Isagi, Dr. Ravi. Yes, you are right, Dr. Abhinya. It is biopsy, but which biopsy? We have two chances or two types of biopsy. One is colposcopic punch biopsy, one is cone biopsy. Yes, you are right. It is punch biopsy. Wonderful. Right. So try to integrate all these subjects together in such type of questions. Let's move further. Match the tools with appropriate analytical property. Now, friends, this is not a difficult question. Only you have to go back to the concept we have discussed. Now, we know precision is when it is repeatably giving you same answer. So consistency, repeatability, reproducibility of a test. Nowadays it is known as reliability. But is your test giving you answer close to the actual value? That is accuracy. Nowadays it is known as validity of the test. Now, when we look at precision, how do we measure precision of a test? It is measured by R chart and range chart. Accuracy is measured by Levi-Jennings chart, mean chart, and Sheward control chart. So now read. Of course, we have taken the examples discussed also in detailed videos. Now read the question carefully. You will find answer to this question is choice number A. R chart is for precision, right? Range chart is for also precision, which is also known as reproducibility. If you look, Levi-Jennings chart is for accuracy. And Sheward control chart, which is a test of accuracy, it tells you repeatedly over a time how much your results are correct. Trend visualization of accuracy over a period of time. Question 33. Log rank test when you compare two Kaplan-Meier survival curves. Log rank test. What does it tell you, friends? When you compare the two different Kaplan-Meier curves. Very good. It compares overall survival experiences between two groups. Now, friends, all of us know this is how a Kaplan-Meier curves look like. Here we have survival, 100%, 90%, 80. After diagnosis, in how many years, how many people continue to survive? So survival keep on reducing for diseases like cancers or diseases which are non-communicable. This is Kaplan-Meier curve. Now, when you look at these two Kaplan-Meier curves, here you can see there are two graphs. The yellow one and the gray one. Yellow one, gray one. Now, what is the difference? Yellow one is without treatment. In graph number 1, this is treatment modality 1. In graph number 2, this gray is treatment modality 2. Can you tell me which treatment modality is better? One is better, two is better, both have same results. Very good. It is treatment modality 2 is better because it is having higher survival if the person is taking treatment. Here, whether the person is taking treatment or not in graph 1, survival chances are same. So this helps you compare two different treatment modalities. And when you compare, we use log rank test. No one will ask you more details in a INI-CET paper, but what they can ask you, when you are comparing these two survival experiences using this log rank test, how do you interpret? We interpret again by p-value. So can you tell me, friends, for a treatment to be better, its p-value should be less than. Complete the answer in the log rank test. Good, very good. It should be less than 0.05 because maximum threshold of type 1 error alpha is accepted to be 5% or 5 by 100 or 0.05. Wonderful. Right. So this is how you have to now here correlate biostatistics with screening of disease. Okay. We are now coming to ROC curve. ROC curve. Can you tell me first question? Receiver operator characteristic curve is drawn between which two parameters? Let me check how many of you remember this older question of INI-CET. ROC curve is drawn between which two parameters? Very good. It is sensitivity and 1 minus specificity. Sensitivity and 1 minus specificity. All of you are right. Sensitivity is the true positive rate. 1 minus specificity is the false positive rate. And then what is the interpretation if I look at graph number 1, 2, 3, and 4? If the graph is a straight line, it is of no use. Upper the curve, better the test. So this is a fair test. This is the good. But ultimately, upper the curve, better the test or the cutoff. Fourth is best. And below that is the area of the curve. So can you tell me which curve will be or which test will be best? Anything which has highest area under the curve. That will give you the best test for detection of that disease. So these are very simple things, concepts. Now, when you go back to your question, they are saying a area under the curve is 0.92. So you can see it is almost very close to 1. So what should be the best answer to this question number 34? Okay, in this graph, you can say it is 4. But based on these choices, what should I mark? Yes, good. This test can distinguish disease versus no disease very easily. True positive, false positive, it can very clearly differentiate, right? So this is a very good curve, ROC. ROC curve is used to trade off between. It is actually, ROC curve is a trade off between sensitivity, specificity. First time, can you tell me where was it used? We have discussed in our live classes also. Where was this used for the first time in the world? It was not used for health and disease. It was actually used in, it was actually used where exactly? ROC curve, receiver operator characteristic curve. It was used in World War to find out places where to drop the bombs. Can you imagine? And somehow it found its place in screening test, right? Okay. Question 35. Again, it is a question which is based on, again, it is a question which is based on ROC curve. You just have to read the question. It was such an easy question. I should now mark the answer. Most appropriate balance. High sensitivity, minimum false positive. Yes, method 4. Friends, suppose you don't know this. You know this is sensitivity. That is true positive. This is 1 minus specificity, that is false positive. Even then you can solve the question. High sensitivity in this direction, minimum false positive in this direction. So this graph is best, having highest sensitivity and least false positive, right? So in INI-CET, a lot of logic based questions will come, provided your concepts are rock solid. You are going to ace the exam, right? So you have to stick to your theory. Best interpretation of data presented in Kaplan-Meier plot. We are looking at again INI-CET questions only, friends. Okay, let us see the diagram in a slightly bigger form. You can see there is treatment A, red color. Treatment A is depicted green. Now you have to decide by reading the choices. What is the correct answer to question number 36? Yes, treatment B has a longer median survival than treatment A. You can see also. See, at 48 months after diagnosis, this is the median survival of patients on treatment A. Roughly around 20% survival, something here. And look at B. It is having 50% survival at that time. So no doubt treatment B has a significantly longer median survival than treatment A. Now let me ask you two higher level questions. One we have already discussed. Now graph is showing B is having higher survival than A. If I want to test it, which test I will use? Test will be log rank test that we have already discussed. And how will we prove it? If my P value comes less than 0.05, I will say yes, B is definitely better than A. My second question, can you tell me What are these shaded areas? These. Slightly high level question, but it has been asked in your INI-CET. I have to tell you. What are these blue shaded areas or red shaded area? Because line is going in the center. These are 95% confidence interval bands. Can you tell me the name of these bands? Can you tell me the name of these bands? Two types of bands are used in Kaplan-Meier curve. Very right, good. It is Hall-Wellner bands. If I don't want to use Hall-Wellner bands, which other bands I should use for 95%? Good, Dr. Isagi. It is Nayer's equal precision bands. Wonderful. Right. So try to correlate these type of topics together. Question 37. Okay, this was an easy question. Pertussis, they are saying whooping cough. Till what time? Period of infectivity, basically, they are asking. What is the period of infectivity for pertussis? Anyone? It is from 1 week after exposure till 3 weeks after paroxysmal stage begins. So, catarrhal part, it is there. Can you tell me what is the contagion period for measles and chicken pox? What is the mnemonic I always say? Chicken pox 25, measles 45. Chicken pox 2 days prior to appearance of rash to 5 days later. Measles 4 days prior to appearance of rash till 5 days later. Question 38. Okay, same concept. Just have to read the choices carefully. Which statement is true? What answer have you marked? Okay, let's go choice by choice. Meningococcal infection cease to be communicable once nasal throat secretions are absent. This is correct. Rubella and measles share the exact same communicable window relative to rash. Yes, it is almost same. Measles is precisely 45. Rubella is 6 to 7, 6 to 7. Almost same. Hepatitis B remain communicable as HBs age is detectable. Okay, this is also almost same. Maximum infectivity is through HBeAg. But only when anti-HBs appear, then we tell the person you are immune to hepatitis B now. Tetanus is communicable in early stage of wound infection. No. Tetanus has no period of communicability. Although it is a communicable disease, but why it has no period of communicability? Because it is only communicable not from man to man, but only from soil to man. Absolutely. Question 39. This is easy. Longest difference in incubation period ranges. Friends, what does it mean? Examiner wants you should know all the incubation periods of these diseases. Polio is 4 to 33 days and hepatitis B is roughly 30 to 1 to 4 months, 30 to 120 days. Trachoma is 5 to 21 days compared to SARS. If you compare to SARS, SARS is a very small incubation period of 3 to 5 days. Ascaris roundworm. Ascaris roundworm is 2 months. Hookworm is also same. It is roughly around 5 weeks to 9 months. But look at HIV. It is from months to years. In fact, median incubation period in India is 10 years. It can go up to 20, 30, 40. Scrub typhus is only 6 to 21 days. Now, friends, in such type of questions, suppose you don't know the incubation periods of all, but you know out of all these, HIV is having the longest incubation period out of all of them. That you definitely know. So such type of questions you can solve logically. Do not leave these questions. At least go through the choices, think logically, whatever you remember, please remember, and then you can solve the answer. So 39 question answer is D for Delhi. Question 40. Question number 40. What is the answer you have marked? First, you tell me, is this a case of no pneumonia, pneumonia, or severe pneumonia? Pneumonia, no pneumonia, pneumonia, severe pneumonia. Good. This is a case of pneumonia. See, once you know this, then it becomes easier for me to tell you. In no pneumonia, what we do is management at home. It is represented by green color, no pneumonia. And management is home is you soothe the throat. You can use bronchodilator for 5 days. If cough is more than 14 days, refer for TB assessment. If there is recurrent wheeze, refer the person for or child for asthma management. Advise mother when to return. But in case there is fast breathing or chest indrawing, new guidelines say chest indrawing is pneumonia. And in this question, you can see respiratory rate 58 per minute in a 3-month-old infant. Look at the cutoff. In 3-month-old, if respiratory rate is more than 50, it is pneumonia. So 3-month-old infant, 2 to 12 months, respiratory rate is more than 50. So definitely this is a case of pneumonia. So in such cases of pneumonia, what is the management guideline which is carried out at this yellow color guidelines? Then what is advisable is try to manage it at PHC using oral amox for 5 days. Amoxicillin is the standard antibiotic used. Rest all remains same. So soothe throat. Bronchodilator you give for 5 days. Cough recurrent wheeze. Here follow up is in 3 days. Because now patient is having pneumonia. In home management, we tell the mother that follow up is in 5 days. You can return early if there is some problem, otherwise 5 days. I'll tell you, Dr. Abhik, IMNCI is these guidelines which are having 5 components: pneumonia, measles, malaria, malnutrition, diarrhea. Flowchart based treatment. In SARS, actually, you are trying to maintain deaths due to pneumonia less than 3 per 1,000 lives. So that program only focuses on pneumonia. IMNCI focuses on 5 diseases along with their complications. That you have to remember. Now, when there is a severe pneumonia, stridor is there or any danger sign is present, in that case, please remember IMNCI uses pink color. They don't use red color, pink. And what do we do is immediate referral to a higher center. Referral, you have to give first dose of referral antibiotic. If convulsions are there, you have to stabilize the child by using diazepam. Keep the child warm. Maintain blood sugar. Right? So home management, PHC, referral, and these are the management guidelines. Now we go to the question. Question says it's a case of pneumonia, bronchodilator trial, but not affect much. So that means now you have to, yes, now you have to go to the antibiotic. An antibiotic of choice is amoxicillin. Call the child after 3 days, as is the guideline in pneumonia cases, right? Okay. So choice number B. Question 40. Okay. A small break. You are very close to the exam now. How many days are left for your exam, friends? How many days are left from today? How many days are left? When is your NEET PG exam? The ultimate exam all of us are preparing for, NEET PG exam. I'm looking at NEET PG first. How many days are left? It is on June 15. So how many days are left? Simple question. 42 days. And what is the importance of 42 days in PSM? All Postnatal visits have to be completed within 42 days by ASHA worker MPW separately because all the problems occur within 42 days. So you also have to visit all your notes, all your text, all the MCQs, all the PYQs, because maximum mortality in MMR occurs due to PPH within 42 days. So you have that crucial period available with you. You have to utilize, right? Okay. Question 41. Okay, this is easy. I'm sure you must have marked this correctly. To understand this, I think have a look at this table. Again, have a look at this table. See, the major marker, of course, there is a combination of markers, but acute hepatitis B is IgM anti-HBC. When we look at vaccination, that means antibody to surface antigen has appeared, person is immune to others, right? There are many other conditions. Like if I'm looking at active viral replication, what should I focus on? HBE antigen. Now go back to the question we are having. They are saying anti-HBS is positive. Person has either been vaccinated or he has recovered immune to hepatitis B. Chronic form is there because not IgM. IgM is for acute. IgG is there. Active viral replication is not occurring now. That means it's a marker of good prognosis. Active viral replication has stopped because its antibody has also appeared. So this is a case of question number 41. Old infection which is now immune. Choice number C. Good. So integrate medicine with PSM. Chemoprophylaxis of cholera. Which of them is true? Which of them is true? Okay, suppose you don't know this question's answer. Even then, logically, you can mark. Yes, accidental doctor, you are right. This is the correct answer. Choice number C. See, in cholera, to prevent one case, chemoprophylaxis is given to 10,000 people. Can you imagine? To prevent one case, you have to give to 10,000 people. We cannot do it. We cannot do it. It is a wastage of resources, right? 10,000 people you give chemoprophylaxis, then one person will be prevented. It is useless. So it is only given to contacts or closed community only. Azithromycin is not the drug of choice for mass chemoprophylaxis. It is tetracycline. So it is not given to all individuals in affected district. It is only given to household contacts or close community. It is not required by all pregnant females, only those in close contacts, right? Okay, so answer is choice number C. Cato-Cat's technique. Chandler index is used, endemic index. This is number of eggs of hookworm per gram of community stool. This is not stool of a person, but of the whole community. So according to classification, it is a major public health problem if more than 300. But they are asking, if it is 240, where should we classify? If it is 240, we should classify as not much significance, potential danger, minor or important. See, this is the classification. If you see, in case it is less than 200 eggs per gram of stool, potential danger if it goes up to 250, minor if it goes up to 300 from 250, and if it is more than 300, which was asked earlier, it is major. Now in this question they are asking 240. So you have to know the classification that it is a potential danger to the public, right? So earlier they asked 300. This time I expect they may ask you potential danger. Question 44. Question 44. At this point, we have discussed today vaccination against cholera and yellow fever in pregnancy. Can you mark the correct answer now, friends? What should I mark? I'm looking at the chat box. Please write the answer. See, this is the importance, unique feature of cerebellum. All majority of sessions are live. We can interact, right? Yes, cholera and yellow fever vaccines should be spaced at least 3 weeks apart. They interfere with each other's absorption. They will not allow each other's antibody formation to take place properly. Question 45. Can you identify the disease which is shown in this particular diagram? So, which disease is this? Question 45. I will tell you why your answer is not correct. Answer to this question is Kaisanur forest disease, also known as monkey disease. Monkeys are the major amplifying host of this disease. When you look at Crimean Congo hemorrhagic fever, then please remember here it depends more on, yes, small mammals, it is also there. It also will have to show not just cow, but definitely camel in the image. When we look at scrub typhus, that is not possible because that is through trombiculate mite. Whereas in this question, they are showing ticks. Read the question carefully. Now, when we look at Lyme's disease, then small birds, you are right, they will have to show squirrels, rats. But the go-to feature which will help you identify it is only KFD, not any other diseases. The monkeys, primates. Therefore, monkey disease is the name given to KFD. Can you tell me the exact name of the species of tick which transmits KFD in India? KFD is transmitted by which species of heart tick? It is Haemophilus. What about Congo fever? So KFD is by Haemophilus penigera. Congo fever is by Hyeloma heart ticks. Right? Okay. Let's move further. Question 46. Mass chemoprophylaxis. When will you start for plague endemic district? Which is the best indicator for potential explosiveness of plague situation? A very popular question. Potential explosiveness of plague situation. Which indicator is used in Indian program, friends? I'm looking at the chat box. Potential explosiveness. Yes, Cheopsis index. Now it is a sign it is going to explode. Start the treatment. Right? So Cheopsis index actually is defined as average number of Cheopsis per rat. Wild rodent Tetra indica is the reservoir. Xenopsilla Cheopsis rat flea is the vector. Yersinia pestis is the causative agent of plague. Which is more dangerous? Which is more dangerous, friends? It is totally blocked flea, open flea, partially blocked flea. Which is more dangerous? Totally blocked flea. Dr. Ashish, number of Cheopsis per rat is Cheopsis index. Totally blocked flea, partially blocked flea, open flea. Which is most dangerous? Partially blocked flea. Dr. Ravi is right. Question 47. Refugee camp. Louse infestation. A few weeks later, previously infected patient redevelops a disease. See, they have given so many clues in the same question. What is the answer? Yes, Brill's insert disease. Brill's insert disease is not a relapse. It is a reactivation of epidemic typhus. What is the causative agent of epidemic louse-borne typhus? What is the causative agent? Partially blocked means the tube is not completely open, partially blocked. So when it tries to bite the person, it uses more force, more quantum of organism is deposited. So they are very dangerous epidemiologically. Vector is louse. Causative agent is Rickettsia prowazekii. You're absolutely right, Dr. Prathi also. Brill Zinsser is a recrudescence. What is the recrudescence of chickenpox known as varicella? What is the recrudescence of chickenpox known as? Shingles or herpes zoster. Question 48. RK39 dipstick test. That is the answer. We are talking of disease. Yes, Kala-Azar. So what is the drug of choice of Kala-Azar in India since last 7-8 years now? It is, yes, liposomal amphotericin B, LAMP. Liposomal amphotericin B. Second line of choice is a combination of peramomycin and miltefosine. Please be careful. Sodium stevogluconate was the older drug of choice. Not used now. But miltefosine, amphotericin B, deoxycholate, amphotericin B emulsions are also used. Right? Okay. Question 49. I think this was again one of the easiest questions of the paper. Non-venereal treponematosis. Can you tell me which diseases are they referring to? Non-venereal means non-sexual. What are the two non-venereal treponematosis? Venereal is syphilis. Non-venereal is yaws and pinta. Causative agent, Treponema pertenu, Treponema cariatium. Now they're saying they treated with penicillin, which is the drug of choice, but new lesions kept on appearing in multiple households. So what they have done wrongly? What they have done wrongly? Because they use the drug correctly. Penicillin, benzathine, benzyl penicillin is the drug of choice. Benzyl penicillin. Which mistake they did? They relied upon sexual transmission routes. Whereas it is mentioned in the question that it is a non-venereal, non-sexual route of transmission. So syphilis is sexual, but yaws and pinta are non-sexual. So can you tell me how do they spread? They spread through direct skin contact. So rather than relying on sexual transmission, they should have checked this person came in contact with which other people through direct skin contact, right? Many times questions have the answers hidden. Question 50, vaginal discharge. Which kit is given? Green kit. Can anyone tell me the number of green kit? Yes, kit number 2. Then they realized when will you replace it with yellow kit? Yellow kit is which kit number? And what is it used for? Kit number 6 used for PID is the clinical diagnosis. Yes, you are right. Lower abdominal pain. So answer is choice number C. So it is not just a vaginal discharge, friends. Please remember, vaginal discharge, cervical erosion, cervical discharge are also seen in PID, lower abdominal pain. So you have to shift the kit. It is not just a simple vaginal discharge which you can treat with only secnidazole, right? You need to treat for PID. Can you quickly tell me which three of them are used for genito-ulcerative disease? I'm trying to see how many of you remember correctly. Which three of them, numbers you can write. Good, Dr. Anchita. These three are used for genito-ulcerative disease. Which of them is used for scrotal swelling? Which of them is used for scrotal swelling? No, not kit number 7. Scrotal swelling. Scrotal swelling is kit number 1. So, cervical discharge, urethral discharge, anorectal discharge, scrotal swelling, kit number 1. This is for inguinal bubo, not scrotal swelling. Inguinal bubo. This is PID and this is vaginal discharge. Can you tell me A new kit number 8 has been launched, brown in color, separately for. Kit number 8, brown in color, is separately now launched for urethral discharge. Good. What is the name of the clinic where these are available? What is the name of the clinic where it is available? Yes, Suraksha Clinic, STD Clinic. And the name of the approach is syndromic approach, secondary level of prevention. Can you tell me how Crimean Congo fever differs from brucellosis? They may have many things which are common to each other, but definitely they have something which is different also. Crimean Congo fever. Yes, good. It is tick-borne, short incubation period and high mortality. It is a hemorrhagic fever, right? Tick we have discussed. So when you look, this is the cycle of Crimean Congo hemorrhagic fever. So it has a tick-borne transmission and then it may reach humans. Can anyone tell me what is the drug of choice for Crimean Congo fever, Crimean Congo hemorrhagic fever in India? Causative agent is nairovirus. What is the drug of choice in India, Indian program? Yes, ribavirin. Good. Ribavirin. Question 52. Hypertension control program in semi-urban population. Primary prevention we want to implement. Today only we have discussed primary prevention is used when a risk factor is present. So what will you do? Actually, it is a very specific words we used for this. Yes, we will try to shift the BP curve to the left. Can you tell me which of them is the right skew, which of them is left skew? Suppose this is curve number 1, curve number 2, curve number 3. Which is right or positive skew? First is right skew. Is it? You are saying first is right skew. No. We always look, as we discussed, we always look at the longer tail, this one. So this is going towards the right or positive side. In first graph, it is going towards left or negative side. Second graph is normal distribution. In right skew curve, mean is how it is related to median and mode. Left will be opposite of that. Let's quickly revise. Good. Accidental doctor is right. Mean is more than median, more than mode. Now, which kind of curve is shown by hypertension in a population? Is it right skew? Is it left skew? I'm asking a slightly higher level question. Which BP curve is shown by adult population where 50% have hypertension? Do we see right skew or left skew in the population? When I'll draw the diagram, it will become very clear. No, not normal. See, it is actually like this. BP, number of people. 50% people are hyper, but other 50% are not hypotensive. Other 50. So if 50% are on the higher side, other 50 are normotensive. So BP curve shows left or negatively skewed curve. Now, when you give anti-BP medication, what will happen to BP? It will start reducing. So a left skewed curve with treatment, we will try to shift towards left side. This was what was asked in the question. So BP distribution curve is already left skewed because longer tail is towards left. By giving antihypertensive or by trying to control or prevent from developing, we are trying to reduce BP. So we are trying to shift BP towards lesser or lower or negative side. So left skew curve of BP shifted towards left side. Please remember. Okay, this was an easy question. Question number 53. Can you tell me? See, when you look at glycemic index, we look at increase in glucose level to our response curve is what is measured. We classify food items into low, medium, high. Can you tell me what is the standard taken for glycemic index? Anyone? What is the standard taken for glycemic index? Its glycemic index is taken as 100. So what are we talking of? What are we talking of, friends? What are we talking of? Standard is glucose. So that will have the maximum impact on your blood sugar level once you consume. Once you consume. Once you consume. See, skewness of central tendency you'll have to learn. When more values are on the higher side, graph is left or negatively skewed. Blood pressure. When you look any adult population, 50% have BP on the higher side. But that does not mean other 50% are hypotensive. They are here, not here. They are normotensive. They are not hypotensive. So majority of people are having BP on the higher side, left or negative skewed curve. When you want to control hypertension, you will either ask them restrict salt, you will or ask them do exercise, you will ask them take antihypertensive drugs. All of them will try to reduce BP. So it is a left skew curve. When you try to reduce BP, curve is trying to shift towards left side. So entire BP curve, we are trying to shift towards left side, right? Okay. Now, low, when we look at low glycemic index, this is value up to 55. Medium is 56 to 69. More than or equal to 70. That is taken as high glycemic index. Now, when questions come in our paper, how do they come? They actually ask you to classify different food items into them. So, when we look at low glycemic index, this includes your grains, most of these cereals, lentils, that is pulses, even pasta. Nowadays, pasta is more processed food, but the original pasta, if you make it yourself, it is having a very low glycemic index. It includes most fruits and vegetables, except, see, this is very simple thing to understand. Whichever fruit vegetable you find very sweet, it cannot have a low glycemic index. So whichever is having more sweetness, like watermelon, will be not having low glycemic index. If you look at sweet potato, word says sweet. So potato may be low, but sweet potato will go into medium. Similarly, if you look at important things like brown rice, basmati rice, they have a lot of carbohydrates. Medium glycemic index, it is there. Even sucrose comes here. Now, what is high? High is all that we like. This includes cornflakes, syrupy food, any syrups that you take. Then it includes rice. It includes potato. Sorry, potato will also come in high, not in low. Rice, potatoes. It will include all types of porridges that we consume. White bread. White bread will also come here. Right? Any candy bars that you love to consume, jasmine rice, baked potato will also come here. Now, look at question number 53 choices now. Now, when we look at question number 53 choices, They're asking which are correct. 2 area, yes, 2 hour response curve. Sweet potatoes are not in low, they are in medium. Brown rice and basmati fall in medium, yes. Lentils are low, yes. So answer is choice number A. See, in multiple choice questions, there are given multiple options. So you have to choose one option. Okay. First, you have to see whether both statements are true or both are false. One is true, one is false. So first you look at that. Waist hip ratio is a better indicator of cardiovascular risk than BMI. First, you tell me, is it a true statement, false statement? Assertion is true or false? True. Now, I want to see whether reason is correct explanation. Waist hip ratio is a better predictor of cardiovascular risk than BMI because waist hip ratio is age and sex dependent and less reliable than skin fold thickness. What is the correct answer you have marked, friends? Yes, C. Why you are saying R is false? Reason तो हो ही नहीं सकता, but why R is false? Because waist hip ratio actually is independent of age. Waist hip ratio in men, women. Can you tell me what is the cutoff of waist hip ratio? What is the cutoff for waist hip ratio to define cardiovascular risk? No, you are telling me older values. Waist hip ratio nowadays more than 0.90 in males, 0.80 in females defines cardiovascular risk, and it is high cardiovascular risk. If this value goes above 1 in men, above 0.86 in women, above 0.86 in women, right? Okay, question 55. WHO steps framework. It is used for non-communicable disease, non-communicable disease, risk factor surveillance and stroke surveillance. So non-communicable disease surveillance and stroke surveillance. See, actually it has got three components. Step 1, 2, 3. In step 1, we have got behavioral measurements, like depending on whether you are a smoker, alcoholic, how much you consume. Step 2 is physical, your height, weight, BP, those we will measure. And biochemical measures that will come in step 3. Biochemical means blood glucose, blood lipid level, right? Now, friends, to solve this question, this is not an easy question because to solve this question, you have to actually memorize all the components of 3 steps. They are divided into 2 groups. We have core set of indicators and expanded. Right? So behavior, physical, biochemical. So answer when you will find to this. They are asking which of the statements are accurate. Which of the statements are accurate? Question number 55. Behavior risk factors are collected in step 2. No, this is not correct. Step 3 is for lipid profile. Yes, it includes HDL. Very right. Waist circumference and BP are in step 2. This is also correct. Waist and BP are there. History of diabetes is only included if biochemical. No, we otherwise also include. So answer is choice number A. So you will have to actually memorize this table. Video will remain in the app, right? Okay. 56. Read the question. Rise in dog bites. Human rabies cases are there. And we want to adopt logical, cost-effective, population-level approach. So what should be done? Again, it was an easy question, friends. What have you marked? Yes, doctor, you are right. Identify and remove all the stray dogs. Vaccinate, remove. You cannot test everyone. Testing will not serve the purpose. You cannot give vaccine to whole population. Health education to population will not work. Disease is fatal, spreading through stray dogs. You have to remove them, right? Vaccinate the remaining. Question 57. Nikshay Mitra Initiative. First, please do not confuse it with Nikshay. Second, do not confuse it with Nikshay Poshan Yojana. So can you tell me what is Nikshay? First question. I am asking this now. What is Nikshay? Older question of NEET PG and INI-CET. What is Nikshay? It is ICT based surveillance system. All dots clinic are connected by this software. What is Nikshay Poshan Yojana? Incentives are given for consumption of dots. Patient is also given. Also it is given. Question number 55 answer was choice number A. Choice number A. 56 it was choice number B. Now, Nikshay Poshan Yojana incentive is given to patient also, dots provider also will discuss. Then, what is Nikshay Mitra initiative? It is a new concept introduced few years ago where corporate sector has been included in TB program. See, all the big companies have something known as CSR, corporate social responsibility in India. So if your profit is very high, let us say more than 5 crores, more than 100 crores revenue, then you have to do 2% as corporate social responsibility, which is not required. But just know, corporate sector has been involved. How they have been involved? That they have to give services to the program. How do they give services to the program? They give not just financial support, or it can be in kind, or even they can give jobs, vocational support to the TB patients. So they have to adopt and give their services. In this, Nikshay 2.0 portal is used to monitor their progress. Nikshay 2.0 portal is there, which manages, okay, this particular corporate house is managing these TB patients or the district. This particular businessman is giving support to this. And what they're doing is managed through Nikshay 2.0 portal. You have to remember. Now, let us read the question. It was launched by President of India in 2022. This is correct. It aims to reduce stigma by allowing adoption of TB patient. Yes. So private sector is adopting TB patients. Only dietary and nutritional support, no. I told you vocational support, financial, all types of supports are given. Corporate bodies can participate, yes. So answer is choice number A. Question 57, choice number A. Nikshay Mitra. Opt-out testing. First you tell me, India uses opt-in testing or opt-out testing? Older question. Which testing India is using? Opt-in or opt-out? Very good, opt-out. What is the difference? Opt-in. I tell you, I want your blood sample. You will opt in. Okay, I am ready. Take my sample. Opt out. I don't tell you first. First, I take your blood sample. Then I tell you, in this blood sample, I am going to do HIV testing. Now you can opt out. You have taken my blood sample, but I don't permit you to do my blood testing for HIV. But opt-out testing is more successful. Why? You can try it, go to any population in the country, and you ask them, do you want to give blood sample for HIV testing? 99% of them will refuse. I don't have HIV. Why should I give my sample? I don't have high risk sexual behavior. They will give all type of excuses. But if you take the sample and you tell them I'm going to test for HIV, they can still opt out. But studies have shown people don't opt out once you have taken the sample. They say, okay. Consent is there in both. It doesn't mean that you will not take the consent of the person before testing. Consent is there in both. So question number 58, answer is, they're asking which is a false assumption. False assumption is B. Consent is required in both opt-in also, opt-out also. In both, consent is required. Please remember, without consent, you cannot test for HIV. Other statements are correct. People are informed, but they may refuse. Testing rate is very high, and WHO this model in developing country like India. Opt out. Phlebotomous urgent types is the vector of Kala-Azar. Sandfly. They are asking which statement is false. So can you tell me, friends, which statement is false? In fact, you can solve this question by exclusion also. If you know the three correct statements, you can mark the wrong statement in this as the answer. Very right. Wrong statement is this. Let's look at other statements. It is a poor flyer. Yes. I told you in the class, live classes also. Sandfly cannot fly. It can only hop. It rests in the cracks and crevices of walls. Only female sandfly transmits Kala-Azar. Only female anopheles transmit malaria. Only female sandfly transmit Kala-Azar. It transmits parasite by injecting pro-mastigotes. Yes, you will study in micro. Now, please remember, phlebotomous urgent types is the vector of Kala-Azar, which is visceral leishmaniasis. But when you look at cutaneous leishmaniasis, it is also by phlebotomous, no doubt. But it is different species. So can you tell me which species of phlebotomous transmits cutaneous leishmaniasis in India? Urgent types can also transmit, but which specific species transmit? It is phlebotomous papatasi and phlebotomous sargenti. So please remember, right? So many such questions you can solve by exclusion, even if you don't know the name of the species. Other three statements you know is absolutely correct. Question 60. ASHA indicators. Okay, before we go ahead, can you tell me the best indicator of ASHA? Best impact indicator or best indicator. Which is that? Reduction of IMR. Otherwise, other three indicators are TB cases in a year, leprosy cases in a year, malnutrition rates. Now, friends, to help you understand this concept, outcome indicator, process indicator, impact indicator. Three types of indicators are there. What I am doing is, I am taking the example of ASHA, then you will never forget. If you, any program, you look at process, outcome, impact. Let us see. We start with first process indicators. So process indicators will be number of ASHAs selected in the state or in the district. I have 10,000 villages. How many ASHAs I have selected in those 10,000 villages? Numbers of ASHA trained. I selected 10,000 ASHA. How many of them I was able to train properly? How many ASHAs attend review meetings after 1 year? This is process of the program. Outcome. What will occur by this? Percentage newborns who are weighed. So in a village, 100 newborns were there in a year. How many percentage of them ASHA was able to take the birth weight record? Percentage children having diarrhea who received ORS. See, process is whether ORS was available. Outcome is whether it was given to the patient or not. Percentage skill delivery. Percentage institutional delivery. Percentage JSY claims. Percentage immunized children. These are outcome. And what is the impact? Did it lead to reduction of infant mortality rate? Did it change the child malnutrition rate? Did it reduce in the village for that particular year? And I told you TB cases detected per year, leprosy cases detected per year. For impact indicator, single best is IMR. Right? So process, outcome, impact. Process, what is going on? Outcome is more measurable in terms of what is achieved by that. Impact is the long-term outcome. Impact is the long-term outcome. Right? So if you look at this, now you can read the question. This is question number 6060. Look at statement A. Percent unmet need is an outcome indicator. Yes, true. Percentage newborn wage is process. This is an outcome. Percentage Asha attending is a process. This is true. IMR is an impact indicator. True. Friends, please check. Is it matching? Is it matching any of the choices? Just please check. True, false, true, true. Answer is A. Answer is A. True, false, true, true. Yes, answer is A. Right? Please check if this answer was marked correctly in the answer booklet. No? Okay. So I'll get it corrected. I'll get it corrected. True, false, true, true. Yes. Right? So answer is A. Answer is A. I'll get it corrected. Right? So this I will change. Because I remember I've seen this some other answer. I don't remember, but I've seen some other answer. Statement B is false. Statement B is false. Question 61. Below poverty line, 1400 received under Janani Suraksha Yojana. She is asked to pay for blood transfusion and diagnostics. How it is a policy breach? This was an easy question, friends. This was an easy question. What should I mark? How this is a policy breach? You just have to read the questions. JSY of 2005, it became JSSK in June 2011. It has two parts, Janani and Shishu. Janani is mother, mother and Shishu is newborn. Mother includes free transport, free drugs, free diagnostic, free delivery, free food supplementation, 3 days in normal vaginal, 7 days in cesarean, free blood transfusion, free surgery. So answer is C. Everything is free. Drugs, diagnosis, treatment, transport, blood transfusion, surgery, food, everything is free. Right? So it was wrongly charged. Question 62. Can you mark the answer, friends? What is the answer to question 62? This was an easy question. In fact, NRHM, NUHM. How do we differentiate that which should go into NUHM is if it is more than 50,000 population in urban areas. So answer is choice number C. So more than 50,000. And where do we take this from? This we take it from census 2011 because after that census is yet to be conducted. Question 63. Question 63. Okay, umbrella program they have made. Now it is known as Saksham Anganwadi and Poshan 2.0. This has got one component ICDS, One component, Poshan Abhiyan. What is Poshan Abhiyan? Anyone? National Nutrition Mission, which covers four diseases: SULA, stunting, undernutrition, low birth weight, and anemia. We have discussed. Then it also includes scheme for adolescent girls and a new national crash scheme. See, these programs were running separately. Only thing they've done is they've combined them together. Ministry remains still the same: women and child development. So these have been together combined into a program known as Saksham Anganwadi and Poshan 2.0. Saksham Anganwadi. You could have solved this question otherwise also, because heart of ICDS in India is Anganwadi. Older question. Heart of ICDS in India is Anganwadi. Is Anganwadi. Right? Okay. Mission Shakti has also been launched by combining multiple programs. One of them is Pradhan Mantri Matru Vandana Yojana. So older programs never stop. They are just given a new name. Pradhan Mantri Matru Vandana Yojana is now a part of Mission Shakti, bigger program. Question 64. Question 64, friends. Which of the following statement regarding daily iodine treatment or intake is true? So can you tell me the true statement? Yes, answer is none of the combination is true. Why? Pregnant females require 250 microgram per day. Okay, let's look at this. School age children, that is 6 to 12 year, require 120 microgram per day. When we look at preschool children, preschool is till 6 years, they will require 90 microgram per day. Lactating mothers require 280 microgram per day. Adults should consume 150 microgram per day. So only correct statement actually. Fourth is not correct. Third is not correct. Two is not correct. One is correct, but combination none of them is correct. Right? So please remember, friends, answer is choice number D, iodine. Can you quickly tell me level of iodization at production level, consumer level? Iodization level at production and consumer level is 30 ppm and 15 ppm. And what is the major impact indicator of iodine program? What is the major impact indicator? Anyone, friends? Next, Dr. Anchita, you are right. Dr. Prathi, you are right. Major impact indicator of this National Iodine Deficiency Disorders Control Program. No, goiter rate is not. Yes, Dr. Ravi is right. Urinary iodine excretion level 24 hours in pregnant females. Okay, this was a easy question. You just have to read about reproductive health indicators. Just read. These are purely based on definition. You cannot go wrong. They are saying which are correct. So you have to read the question also. TFR, total births to a woman. Yes, this is correct. Gross reproduction rate, number of daughters. NRR is 1 when population is replacing. One dying woman is replaced by a newborn girl child. GFR considers all live births divided by total median population. No, it's not total median population, but it is total median population of reproductive age group females. So 1, 3, and 4 are correct. Answer is A. Choice number A. Question 66. Annual growth rate 0.3%. This will be which category? Now, friends, growth rate based phases are there: slow, moderate, rapid, very rapid, explosive. No, reproductive age is 15 to 49. There is no update. Reproductive age, how can that change? Rather, reproductive age should be lowered to below 15 now. Puberty is occurring at a younger age now, right? Reproductive age is 15 to 49 only. There is no update. Annual growth rate is 0.3%. So you have to remember this classification, which is in demography, that if it is 0% annual growth rate, then population will remain stationary. But if it is less than 0.5, 0.5 to 1, 1 to 1.5, 1.5 to 2, then you can say more than 2. But it is 2 to 2.5, 2.5 to 3, 3 to 3.5, like so on. Now, how many time it takes for population doubling? Can you tell me where is India in this? India is in which growth phase? How much is the annual growth rate of India, friends? Moderate growth, no? India's growth rate is 1.64%. A question of your NEET PG. Very rapid growth phase. India's population doubling time has been asked in your paper. 35 to 47 years. I'm writing in opposite direction. 47 to 35 years, but it is 35 to 40. Okay, let's not confuse you. Let's write 35 to 47 years. So slow growth takes more than 139 years to develop. Moderate growth 170 to 139 years. Then 47 to 70 years. And this will even double faster, less than 35 years. Explosive, right? When you forget everything, you're not allowed to forget India. So very rapid growth phase, population doubling time. So when you look at question number, this is 66. They're asking 0.3%. 0.3% will make it slow growth. So doubling in more than a century, more than 139 years. Okay. Can you tell me which of them is developing country, which is developed? Developing is first or second? A or B? A is developed. Good. What is the typical shape of developing country? You have to remember technical words. It is upright triangle having a broad base, narrow top. Developed country is spindle shape. You can see this spindle like this. So this is spindle shape having a bulge in middle. These technical words you have to remember. Now let us read the question. Question says, which best reflects in country A? So dependency ratio challenge and its economic consequence in country A, you have to read carefully. So friends, what should I mark? You just have to read, it will become very clear. Yes. Country A's old age dependency will increase. So pension burden will increase, workforce will reduce. Look at it, developing country like India. Slowly and slowly, they will enter, these children will enter the earning age group. So workforce will increase. In fact, this is what we say that our demographic dividend will now pay. Our children will enter the economically productive age group soon. Okay, Pearl index calculation. What is the formula of Pearl index, friends? It is defined as number of accidental gestations. Accidental pregnancy means despite using the contraceptive. divided by total months of exposure or usage. Multiplier is unique, 1200, because we have to express it per 100 women years. So this was again one of the easiest questions of our paper today. Accidental pregnancies 18, total woman months of exposure 2700, multiplier is 20. So you know the formula, you know the answer, it will come 8. Yes, so it will come 8 per 100 women years. Automatically, it means if 100 women use this contraceptive for 1 year each, 8 of them will become pregnant despite using this contraceptive. Absolutely. Which contraceptive is shown in this image, friends? Which is this contraceptive? This is diaphragm. So when we look at diaphragm, cervical caps, these are non-conventional. They have to be left or they have to be inserted 6 hours prior to intercourse, should not be removed for 6 hours later. Otherwise, failure will occur. What is the potential life-threatening complication if it is left after 6 to 8 hours? What is the potential life-threatening complication, friends, if it is left after 6 to 8 hours? Toxic shock syndrome, Staphylococcus aureus, death occurs. Now, it yes offers protection against pregnancy, but as compared to condoms, its protection against HIV STD is very limited. Condoms are much better in protection, although both are barrier methods, right? So it has to be inserted 6 hours prior to intercourse, should not be removed for 6 hours later. And which woman is best suited, older question, for giving diaphragm? Which woman is best suited for giving diaphragm as a contraceptive? What is the key word or what is the key feature of woman who can use? Yes, it is educated female. So it is a temporary method only for educated because it has to be reused, wash, dry, reuse. Technique of insertion is difficult. It should be used along with spermicide, non-oxynol 9. So these problems and TSS makes it only suitable for a educated female. Question 70. This was an easy question. You have studied in obs gynae also. I think you have studied in medicine also or surgery also. PSM, of course. So what can I mark as the answer, friends? Yes. देखो. For OCP, age of the woman creates risk. And on top of that, if she is a smoker also, that further compounds the risk. So she has to be given them with caution. If I look at India, not these are the global guidelines. If I look at India, age more than 40 years is a relative contraindication. In India, age more than 35 years is a relative contraindication if it is a smoker woman. So definitely smoking increases the cardiovascular risk. OCPs have to be given very carefully. Question 71. Okay, this everyone knows. So you just have to tell me the correct answer. Okay, let's quickly go through this. Up till what period of gestation MTP is allowed in India? What is low risk? What is high risk? It is allowed till 24 weeks period of gestation. Low risk is first 20 weeks. High risk is next 4 weeks. High risk includes 4 categories of women. High risk include 4 categories of women. These are rape, incest, very right. Two more are left. Can you complete the list, friends? Rape, incest, disability, or woman is a minor. Everything else goes into low risk up to 20 weeks. This is mainly including contraceptive failure also. Please remember, in low risk, only one doctor's opinion is sufficient. In high risk, two doctors' opinion is required. Can MTP be done in India after 24 weeks? Yes. There has to be court, there has to be medical board. But it is again done only in one condition. Can you tell me which condition? More than 24 weeks. No, I want the exact answer. Exact answer, make it a chocolate question even if you want. I want exact answer because that will be asked. What is the word used in the MTP Act? Congenital anomaly, no. It is substantial congenital anomaly. So you have to use this word substantial anomaly. And who is there in the medical board? Obstetrician, gynecologist. Answer is they are asking correctly matched. So this is correct match. Other you can read, right? One best answer for weeks allowed in MTP, 24 weeks, friends. This is mentioned in the program. MTP is allowed in India up to 24 weeks. Beyond 24 weeks, you have to approach court of law. They will constitute a medical board. They will take a decision if it is to be done and how it is to be done, right? 72. Okay, again, incubation period, longest to shortest. So best is when you get some questions like this, you first think of their incubation periods. It ranges from weeks to years, goes up to 5 years, to 2 to 5 years. HIV/AIDS, months to years, 20 years, 30 years. India median is 10 years. Hepatitis B, 45 days to 180 days. That is 6 weeks to 6 months. And when we look at leptospirosis, it is 4 to 20 days. So now you can see which answer is correct. Longest to shortest. Yes, choice number B. Choice number B, right? Question 73. Okay. Incentives. Okay, let's go statement by statement. They're asking which statement is true. Patient are given fixed dose combination to reduce pill burden. This is correct. Statement 2. Incentive for DOTS provider is higher for MDR, higher than the patients. Yes, higher for MDR, XDR than category 1 patient. Can you tell me what is the incentive for DOTS provider? Patient always get 1,000 rupees per month. Earlier it was 500, now it is 1,000 for all the DOTS patients. But when we look at providers, how much they get for category 1 patients and 2 patients, they get 1,000. But here they get 5,000 on completion of treatment. On completion, patient will get every month. They will get only on completion of treatment 1,000 in category 1 and 2, 5,000 in MDR, XDR. So this is also a true statement. Extension of intensive phase is not done now. It was done 10 years ago. Now we don't do. 5,000, not 3,000, 5,000. Pediatric patient receive bitter drugs. No, no. It has changed in the program 7, 8 years ago. Pediatric patients received flavored. Otherwise, why will they consume? Flavored syrup, flavored tablets, we have to remember. Right? Okay. So if you look at question number 73, answer is choice number 1 and 2 are correct. A. Choice number A. Question 74. Okay. What is the treatment of mixed infection when it is a combination of Vivex and falciparum? Treat them with, treat them just like falciparum infection. Treat them like falciparum because falciparum is more dangerous. 75. Anemia Mukt Bharat. Can you tell me this table. I just need 5 more minutes, friends, then we'll wrap up. Iron, folic acid, frequency, color. Because you know a question is going to come from this, we cannot do wrong. So iron is in milligram, folic acid is in microgram. So this is 20 and 100. 5 to 9-year-old child, 45, 400. All other are 60 and 500. Anywhere I'm writing wrong, let me know. I'm going very fast, but I'm presuming all of you know this. Yes, Dr. Accidental Doctor is right. When we look at their frequency, can you tell me, friends, when I look at their frequency, what is the frequency? Here it is bi-weekly. Here weekly, 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 daily, daily. Here it is given for 180 days each. Color, this is a syrup. But when we look at all the others are tablets. When we look at lower three, these are red colored tablets. When we look at adolescents, these are blue. And when we look at 5 to 9 years, they are pink. Please confirm if I have written correctly. Please confirm if I have written correctly. So this is Anemia Mukt Bharat program. What is the strategy? 6 by 6 by 6. 6 beneficiaries in front of you, 6 interventions, 6 institutional mechanisms. We have to reduce prevalence of anemia by 3 percentage points every year, 2018 to 22. Very right. So you just have to read the question carefully. What should be the answer now? They're asking correct combination. Yes, answer is B. Now, friends, before we go, 75 questions you attempted. First, you tell me 2 bonus questions I'm putting. Can you quickly solve these 2 bonus questions by reading right now? I'll take maximum 3-4 minutes more. We'll finish this topic. Which is false statement they're asking. Actually, I made 77 questions by going through all the topics. They were asked to select 75 on their own. So software picked those 75, 2 were left. Which statement is false? False statement they're asking. This is correct. This is correct. This is correct. So by exclusion, you can solve. Nowadays, please remember, although there is some risk in equine rabies immunoglobulin, but the problem is we don't have any other option. Rabies is a 100% fatal disease. Prior skin testing is not done now. Prior skin testing is not done now according to latest guidelines. We have to remember. Bonus question 2. Can you tell me what is red line? Okay. Can you tell me what is green line? Can you tell me what is yellow line? Yes, green is birth rate, red is death rate. So what is this orange line? Sorry, not yellow, I shouldn't say. What is this orange line? This one. Yes, good. Total population. So answer to this question, they are asking red line, that is death rate. Can you tell me, okay, now I will test your actual concept. Can you tell me what will happen to orange line in phase or stage 5? In the last stage, which is not given in the diagram, can you tell me high expanding, sorry, high stationary, early expanding, late expanding, low stationary, declining phase? What will happen to orange line? Yes, it will start reducing. What will happen to red and green? What will happen to red and green in fifth stage? No, both will not decline. No. Yes, good. Red will remain high, but birth rate will decline even more. Deaths will appear higher than births. Population will decrease. Wonderful. Thank you so much, friends, for your time. First, you tell me how many answers were correct out of 75. How many were correct? You know your score, right? Okay. If you're not sharing your score, I will tell you. If you've scored 60 plus, amazing. Because I made all the questions myself, all the choices. I tried to combine multiple questions. I tried to make lengthier choices. This is how actually questions will appear 40 to 50% in your exam. If you scored between 50 to 60 or 50 to, let's make it 59, then it is really good. Exam is there for you to take. But friends, if you have scored less than 50, then we need to practice a lot more questions. Your theory may be good, but only theory is not sufficient. You have to put in a hard work, practice as many PYQs, late night questions as much as possible. Now, I started my professional career with United Nations. I got a chance last month to visit there, right? So this will tell you, you have to believe everything is possible with you. Please keep on working hard. There is no shortcut to success. You'll have to give 100% in the upcoming examination. Still, any question is left, my WhatsApp number I'm sharing with you. Please feel free. Although I get 300 to 400 messages daily from students, but whichever I'm able to see, I try to respond as much as possible. Otherwise, Cerebellum Academy is there, and we will definitely keep on meeting you in all such live sessions. Right? Thank you so much. Yes, I will ask the team if they are sharing daily PDFs. This annotated PDF will also go in the team. Thank you so much, friends, for sitting with me continuously for 4 hours. It's not easy, but this is the effort you will require for your exam. Thank you so much for your time. Any non-academic question you can have or you are having, we can quickly take in next 5 minutes. Any non-academic question? Thank you so much, Dr. Anchita, Dr. Aditi, Dr. V. Ravi Krishna, Dr. Abhinaya, Dr. Bhargavi, Dr. Shubham, accidental doctor. How to revise PSM in a short span? Attend the upcoming marathon session. 5 hours, I think I will take to again revise PSM. If you need more than 5 hours, go through rapid revision videos of 10 hours. If you need more, go through 40 hours of mission videos. If you need more, go through 45 hours of main videos. Dr. Abhigya, if for 2026 you are preparing, no, rapid revision videos are very much insufficient. They are just 1/5 of the total course. I will suggest you have enough time, go for main videos, revise with mission videos, then revise with rapid revision, and ultimately revise with ENDs and marathon session. Multiple 5 readings are, I think, more than sufficient along with notes. 2025, you have no option. Rapid revision videos, marathon videos are the option, right? 2026, you have a lot of time. Please go to main videos, attend all the mission live sessions. Your theory will be very concrete and very solid by that time. Right, friends? Okay, thank you so much. So let us wrap up the session. Mission videos start with lap 1 if you have. Okay, Dr. Aditi, what I will suggest is mission sessions will be there for 2026 separately. So right now you can start with main videos. In case you want to start with mission, that is also fine because main and mission are almost same. But new mission sessions will keep on coming. New mission sessions will keep on coming. Thank you so much, everyone, friends. So I wish you all the best. May all of you get the dream branch of your choice in the dream college of your choice. So take care of your health, keep on studying, and stay with your parents. Be connected with your parents and teachers always. Thank you so much, friends. Career option PSM, there is a video on Cerebellum YouTube channel. You will find there. Thank you so much, friends. Take care. Bye bye. Namaste. Dhanyavad.